afternoon, everyone. Thank you for joining me today. It's an honor to be here representing the front lines of primary healthcare and sharing insights from my publication, A Holistic Approach to a Complex Traumatic Wound in the Lower Limb. Let's start with a simple fact. Skin lesions, often underestimated, contribute significantly to morbidity, mortality, and healthcare costs. Among these, traumatic wounds represent over half the visits to primary care centers. These numbers highlight an urgent need for innovative, multidisciplinary strategies in wound care. Among the factors associated with skin lesions, malnutrition in general and nutrient deficiencies in particular play a prominent role in their development. Disease-related malnutrition and vitamin and micronutrient deficiency determine the clinical prognosis of patients at risk. Identifying and treatment malnutrition is essential both to prevent the development of wounds and to achieve adequate wound healing, which requires energy and nutrients. To tackle this, I employ the GLAM criteria, a global standard for assessing malnutrition. Malnutrition, after all, isn't just a clinical backdrop, it's a central player in wound healing. This comprehensive approach enables to classify the patient's nutritional risk accurately and tailor an intervention. The criteria included in this consensus can be divided into phenotypic criteria such as unintentional weight loss, low BMI, and reduced muscle mass, and etiological criteria such as reduced intake or assimilation, disease burden and inflammation, and acute or chronic disease-related illness or injury. The diagnosis of malnutrition requires at least one etiological and one phenotypic criterion. It's also recommended that malnutrition be classified into stage 1, moderate, and stage 2, severe. The GLAM criteria are intended to be simple and easy to apply, thus establish a new international consensus for diagnosing the degree of malnutrition. What makes this case unique, however, is the use of dominate acronym, a structured approach ensuring no aspect of care is overlooked. From managing inflammation and infection to employing advanced compression therapy and dietary modification. This method emphasizes treating the wound holistically, not just the visible injury. On the other hand, the inflammatory process inherent in lower limb wound involves an alteration of the microcirculation, with increased capillary filtration and due to gravity and it affects an increase in intravenous pressure. Therefore, in the absence of reflux or obstructive symptoms, a state of venous hypertension may occur, which hinders and complicates healing. There are therefore a number of wounds that do not meet the definition of a venous ulcer but behave as such. We can therefore conclude that compression therapy is essential to combat venous hypertension due to the benefits it provides. By combining these three pillars in our approach to wound, we will be able to treat them in a comprehensive manner based on the patient and their characteristics, as well as the diagnoses and pathologies that may be interfering with the healing process. I'd also like to emphasize the role of patient education. It's one thing to treat a wound, it's another to empower a patient to practice actively in their healing journey. Teaching them about compression therapy, nutritional adjustments, and recognizing warning signs lays the foundation for sustained recovery and prevention. Through my case study, I am to bridge the gap between data and practice. The case revolves around 80-year-old woman, a diabetic patient who sustained a contused wound from seemingly minor accident. However, as many of you know, a simple injury in vulnerable patient can cascade into a clinical challenge. In terms of examination and complementary tests, we have an X-ray of tibia, fibula, and knee carried out in the hospital emergency room, which rule out any signs of fracture. Presence of pulse in both lower limbs, calf circumference of 30.5 centimeters, height of 163.5 centimeters, weight of 53.5 kilograms, and BMI of 20. In an MNI test for malnutrition was performed with a score of 10 indicating risk of malnutrition and VAS pain score of 5. If we analyze the GLAM criteria, we obtain as a phenotypic criteria BMI less than 22 in adults over 70 years and reduction in muscle mass. In terms of etiological criteria, we obtain an inflammatory burden due to an active injury. Therefore, in accordance with the GLAM criteria, our patient has moderate malnutrition. We will now analyze the acronym DOMINATE. We start with debridement. Initially, the wound has a small area of slough, so debridement with a polyacrylated polyabsorbent fiber dressing is chosen. As for offloading, the patient is advised to rest in relation to the pain. Regarding moisture, the wound is slightly moist, so hydrogel is applied to allow healing in a moist environment. The wound showed no signs of malignancy, and there was no need to stop any treatment that might interfere with healing, as the patient was not on any chronic treatments. Mental health assessment, a first-line analgesic regimen was administered. Continuing with the acronym analysis, no signs of infection were observed, so no treatment was required. Signs of inflammation decreased with the use of multi-component compression therapy. For nutritional management, a varied diet with increased protein, vitamins, and adequate hydration was recommended. The diet was supplemented with a single-day dose of a neutral protein module until dessert. We ruled out arterial pathology as the patient had pulses in both limbs. Advanced wound healing techniques were applied using a multi-component compression bandage and a metalloprotease modulating dressing. The wound was free of edema and the patient was educated about care, warning signs, and the importance of adherence to treatment and diet. This image corresponds to wound care step 6, and this is the start of the comprehensive wound assessment known as DOMINATE. The beginning of the application of the DOMINATE acronym, as well as compression therapy, was delayed because she was initially treated by another specialist. The treatment technique is similar to that used previously: washing, hydrogel, and polyacrylated fiber dressing. What was new was the use of a multi-component compression bandage. After 24 hours of wearing the bandage is checked and the leg is hydrated using the same treatment technique. The next treatment, the wound was observed to be progressing favorably, so the same treatment regimen was maintained and the protein supplementation was started. 10 days after the start of the comprehensive assessment, we observed a clear improvement and a significant reduction in size, so treatment guidelines and recommendations are maintained. After 17 days, we estimate that the patient is almost fully recovered and ready to be discharged for the next treatment. I'd also like to emphasize the role of patient education. It's one thing to treat a wound. It's another to empower a patient to practice actively in their healing journey. Teaching them about compression therapy, nutritional adjustments, and recognizing warning signs lays the foundation for sustained and recovery and prevention. The results? Within 24 days, this patient achieved completely healing, an outcome made possible through the collaboration, cutting-edge techniques, and compassion. So, what's the takeaway here? As healthcare professionals, our role extends beyond diagnosis and treatment. It's about understanding the person behind the patient, recognizing the interplay of factors that influence outcomes, and being relentless in our pursuit of holistic care. Let this be an invitation to you all, wherever you enrich, practice, or polish. Remember that innovation in care begins with willingness to look beyond the surface. Please don't hesitate to contact me if you have any questions. I look forward to hearing from you.
of the skin and intestine in children with atopic dermatitis, the relationship, the possibilities of prebiotics and probiotics therapy. Подключается. 1 minute. Yes?
Yes, it's visible, doctor. Please proceed. Please proceed with your next slides.
Next slide.
Yeah,
Thank you.
yeah.
Atopic dermatitis is a multifactorial uh, inflammatory skin disease characterized by an itching and chronic relapsing course, age-related features of the localization and morphology of lesion. Epidemiology of AD in children from 20 to 40% in the structure of the skin disease in person of both sexes and in different age group. The prevalence of atopic dermatitis among children is up to 20%, among adults between 2 to 8%. Main factors is the development of atopic dermatitis. Presented on this slide include genetic predisposition, future of the immunological response, dysfunction and defects of the skin barrier, filaggrin, etc., skin microbiome disruption. The barrier function. The barrier function of the skin depends on an interaction of different layer of the skin, defect in the filaggrin gene, congenital defects of the gene encoding components of cortiodesmazine, a violation of the lipid barrier. The skin microbiome is a complex dynamic system that plays an important role in maintaining the integrity of the skin barrier. In AD, the skin microbiome is characterized by reduction in the biodiversity of bacterial species, reduction in the content of actinobacteria and proteobacteria, growth of staphylococcal colonization, Staphylococcus aureus, and other. Skin-associated lymphoid tissue, SALT, is part of the mucosal immune system. Interaction of skin microbiome components with SALT immunocomponents cells directly or indirectly leads to the activation of local and systemic immune response. The modern medical literature discusses the role of transcutaneous sensitization in the development and cause of food allergy in children. Exposure of food allergens through the skin barrier bypasses the mechanism of oral tolerance development, and when the gut is exposed to food allergen, previous sensitization experience with the same allergens, previous sensitization experience with the same allergen via the skin root result in more severe AD symptoms. The possibility and intensity of transcutaneous sensitization directly depends on the state of the skin barrier function. It is assumed that emollients creating a protective film in case of congenital defects of the skin barrier should prevent the penetration of the allergen and accordingly the development of sensitization. However, studies devote to the preventive effect of emollients have contradictory results. Information accumulate about the gut-skin axis The gut-skin axis is a complex dynamic system that plays an important role in maintaining the integrity of the skin barrier, a suggestion of an intrinsic link between the gastrointestinal microbiome and the skin microbiome, the result of various pathological disorders of the axis, which can lead to the development of disease like um, atopic dermatitis, etc. Intestinal microbiota is a metabolic organ, is a source of biologically active substance, one of the which is short chain fatty acid, SCFA. SCFA plays an important role in the function of the intestine and the microorganism as a whole. SCFAs are formed by bacterial fermentation of dietary oligosaccharides. SCFAs perform important functions in the body such antibacterial effect, fat reduction, and increased tissue sensitivity in insulin. SCFA and the microorganisms that produce them. The main producer of acetic acid C2 are Bifidobacterium, Lactobacillus, and other. For example, the main producer of propionic acid C3 are Veillonella, Propionibacterium, and other. The main producers of butyric acid C4 are Faecalibacterium prausnitzii, Eubacterium, and other. Purpose of the study. Based on a dynamic analysis of a clinical picture, skin and intestinal microbiome, this study evaluates of effectiveness of treating AD in children with the inclusion of a complex of prebiotics and probiotics biotic complex in external therapy. Material and methods. A total of 19 children, 9 boys and 10 girls with AD in the stage of subsiding exacerbation, aged from 2 months to 5 years, were examined, who were treated with a series of products with a biotic complex, prebiotic inulin, and oligosaccharides, lactobacilli, as external therapy. At the time of inclusion in the study and after 1 month of therapy, SCOID, pH, and skin moisture, we assessed NGS sequences in biotopes of affected skin areas as well as intestines in fishes before and after 1 month of therapy includes the following assessment: Shannon Microbiota Biodiversity Index, PILO Index, and study of bacterial communities by phylum, class, family, genera, and species in affected areas of the skin and in the intestine. The study of spectrum of short-chain fatty acid SCFA fraction C2C6, acetic, propionic, butyric, propionic acid isoforms in fishes in children with AD using gas liquid chromatography. Statistical analysis was carried out using the statistical software package StatTech Russian Federation. You can see the inclusion and exclusion criteria in the study on table 1. One patient was excluded from the study because he was prescribed a probiotics preparation orally by his pediatrician. Let me show you our results. Table 2. Dynamic of clinical manifestation and SCORAD in children with AD before and after therapy with biotic complex. The severity of such symptoms as erythema, dry skin, itchy skin, skin lesion area, SCORAD become statistically significantly less after therapy with biotic complex. Table 3. Dynamic evolution of skin moisture level in children with AD. The skin moisture level has positive dynamics on torso and limbs after therapy and moisture on cheek skin become statistically significantly more after therapy. Next slide. Table 4. The skin pH level has positive dynamics in all research areas after therapy with external biotics complex. The role of opportunistic pathogens in reducing skin microbiota biodiversity in children with AD before treatment. With an increase in the level of this microorganism on the skin, there was a decrease in the Shannon and PLO indexes and a decrease in the biodiversity of bacteria on the skin. Table 5. The relationship of SCOID index and microbiota on the affected skin areas in children with AD after treatment. With an increase in the phylum Actinobacteria, there was a decrease in the index SCOID. Actinobacteria is a natural inhabitant of the skin. We see positive dynamic of Shannon index on the affected skin areas of children with AD after treatment with biotic complex. We see a positive dynamic PLO index on the affected skin areas of children with AD after treatment. As can be seen from this figure, we observed a direct correlation between the severity of damage to the skin and intestinal microbiome. Relationship between SCFA isoforms in the gut and skin bacteria we can see on this slide. SCFA isoform produced only pathogenic bacteria. With an increase in the content of fatty acid isoform in the intestine, there was an increase in the content of opportunistic microorganisms on the skin, Staphylococcus, Streptococcus, and other. A direct correlation was found between SCORAD index and content of fatty acid isoform in the intestine. On this slide, we can see relationship between fecal SCFAs and the skin microbiome index Shannon. With an increase in the Shannon index on the skin, there was an increase in acetic and butyric acids and a decrease in the content of fatty acid isoform in the intestine. Our conclusion. AD therapy using external CAR products with a biotic complex made it possible to achieve positive change in functional indicators in the skin microbiome with a clear positive clinical effect. The conducted study recommends supplementing external prebiotics and probiotic therapy with oral probiotics preparation to correct concomitant and pathogenically associated dysbiotic change in the intestine. Improvement of functional indicators and the skin microbiome helps to reduce defect in the skin barrier function, which is vital in the development and progression of AD severity, reducing the risk of transcutaneous sensitization. Listen to macrocare about skin microbiome. Listen to biotic complex with probiotics Lactococcus, Lactobacillus, and Bifidobacterium, and prebiotics Trihalose and Inulin. On this slide, we can see group of K product with biotic complex, daily K, nutrition and hydration, and special K from Lesanti. On this slide, we can see lipid reduction cream, intensive nutrition, function A, normalize the water lipid balance of the skin, prevent moisture loss, provides intensive nutrition, stimulates skin regeneration and relieves irritation, increases the elasticity and firmness of the skin. Active ingredients we can see on this slide. Muse with triple action intensively moisturizes the skin, saturating it with moisture, fatty acid, vitamin E, B5, significantly reduce dryness, inflammation, and peeling, smoothes micro-relief. Thanks to its airy texture, it is quickly absorbed, providing a long-lasting feeling of comfort. And cleaning cream, cleans cream gel gently cleanses so that the skin relieves itching, gives a feeling of comfort and hydration after washing. Maintains a protective layer, active ingredient we can see on this slide. Thank you for your attention. On this slide, our afters team. Thank you. Our email. Goodbye.
Thank you so much, Dr. Shablav. It was truly insightful.
Thank you. I would like to thank the scientific community for accepting our work entitled Vulvar dermatofibrosarcoma of Darier and Ferrand in a young woman about the observation. Darier and Ferrand dermatofibrosarcoma is a rare mesenchymal tumor in young adults, often located in the trunk. We report on observation of a vulvar localization of dermatofibrosarcoma, Darier and Ferrand. What was the clinical history? That was a young patient aged 25 who presented a tumor of the vulvar region. This tumor has been evolving for about 10 years in two phases. The first of which is longer with very slow development. The second phase characterized by rapid growth of the tumor coinciding with the start of pregnancy. On admission, the patient had a clear conscience and in good general condition with a Glasgow score of 15 out of 50. Dermatological examination showed a genital tumor measuring approximately 10 centimeters, painless to palpation of firm consistency located at the level of the left lip, with superior development towards the pubis, raising the vulvar relief and hindering the opening of the vaginal orifice. There was no discharge or genital ulceration. Examination of the splenoganglion system did not show any adenopathy. The rest of the clinical examination was normal. This picture shows the Darier and Ferrand dermatofibrosarcoma of the vulvar region. The histopathological examination showed a sarcomatous proliferation with spindle-shaped cells containing elongated and moderately dyskaryotic nuclei with elongated cytoplasm. Examination not a stoiform arrangement of tumor cell with a fishbone appearance. Mitosis were few, less than 10 mitosis per 10 field at high magnification. The stroma was fibrillar and the surface epithelium was regular. So the diagnosis of dermatofibrosarcoma was returned. The treatment consisted of resection surgery with a monoblock excision with wide margin of 5 centimeters, except for clitoris and urethra, where the margins were reduced to 2 centimeters. Reconstruction by sample suture was performed, followed by neoadjuvant radiotherapy. The evolution of the post-operative follow-up was good, at the cost of an amputation of part of the affected vulva. This picture shows the post-surgical aspect of vulvar dermatofibrosarcoma of Darier and Ferrand seen in the immediate post-operative period. Now I'm going to make some comment for this clinical case. Dermatofibrosarcoma was first described by Taylor in 1890, individualized as a true anatomical clinical entity in 1924 by Jean Darier and Marcel Ferrand. It is a tumor with dermal origin intermediate malignancy that represents less than 2% of all soft tissue sarcoma. It may be located on any organ, but affect tongue with predilection, limb, hand, and neck. Vulvar localization is rare, described mostly in isolated cases in the literature. Clinically, great variability in its presentation. Initially, appearance of a small nodule or single-form plaque. Initial lesion slowly grows over several months or years to painless dermal formation. At more advanced stage, the plaque spreads, the surface becomes irregular, realizing often sometimes a multinodular polychromatic mass or sometimes uninodular. We present a case of endonodular protuberant dermatofibrosarcoma of Darier and Ferrand. However, despite this rather characteristic clinic presentation, the diagnosis of certainty is based on anatomopathological examination. The reference treatment today remains excisional surgery, which should be performed in monoblock with resection margin of at least 4 centimeters down to the facial plane and depth. An alternative to this wide surgery is the most micrographic technique, which involves an extemporaneous examination and 3 centimeters margin. Complementary treatment are sometimes proposed. For example, some authors have used radiotherapy for recurrent tumor. Oral imatinib mesylate is a tumor cell-targeted therapy that has also been used in recurrent, metastatic, or unresectable tumor with encouraging results. In conclusion, dermatofibrosarcoma is a rare tumor of intermediate and local malignancy, exposing to the risk of recurrence. Our observation confirms the possibility of vulvar localization. Surgery is a cornerstone of treatment, but the most faces the challenge of safeguarding the function of the organs in the region. Thank you very much.
University of Campinas, here in São Paulo, Brazil. And today I will present our study titled Plastic Surgery and the Celebrity Behavior Change, Hiding and Unveiling. This work explores how female celebrities' publicity relate to their plastic surgeries and how this affects the visibility of the specialty. Plastic surgery has gained significant media attention, especially here in Brazil, with the recent resolution of the Brazil's Federal Council of Medicine, number 2336 from 2023. This resolution allows broader dissemination of medical services, including cosmetic surgery. At the same time, women make up 86.3% of plastic surgery patients worldwide, a number influenced by body disaffections and social culture pressure. The media also plays a powerful role in shaping these perceptions. So our goal was to develop a reference panel of real cases showing how female celebrities approach plastic surgery in public. We aim to analyze this behavior, whether they hide or they reveal their procedures, and how this affects the image of plastic surgery in society. So this is a qualitative, descriptive, analytical study. We collected content from websites, magazines, newspapers, and social media in both English and Portuguese. The sources came from Brazil, United Kingdom, and United States, and we selected 10 publications that featured real celebrity cases. This is to show the lack of results in PubMed when we search for plastic surgeries in social media and famous person. So historically, many celebrities hid the fact that they had undergone plastic surgeries. For example, Marilyn Monroe never admitted that she undergone any procedure in her life. However, X-rays released decades later show chin and breast silicone injections. Renowned personalities in the 21st centuries are still reluctant to publicly admit their plastic surgeries, despite having notable transformations in their physical appearance after becoming famous. An example of this phenomenon is the Swiss media personality Jocelyn Wallenstein, that denies having undergone any procedure, even though her appearance reveals typical characteristics of successive surgical approaches. In 2010, for example, media speculated about Kim Kardashian's Brazilian butt lifts procedure. Another example is Jennifer Lawrence, that she also denied at first, but later confirmed a rhinoplasty. This shows a cultural pattern of concealment. But in contrast, some celebrities have chosen to be open about the plastic surgeries. A famous case in Brazil is the singer Anitta, who appeared in national television in 2013 with a bandage on her nose right after her rhinoplasty. Also, in this direction, the TV presenter Xuxa, also publicly discussed her breast surgeries. This marked a shift toward transparency. We observe a clear change in behavior. Plastic surgery is no longer a taboo, but a topic to be openly discussed by public figures. This openness helps normalize the procedure and make them more socially acceptable. As a result, even ordinary patients are more willing to share their own experiences, especially on social media. The media plays a key role in this process. A study in Brazil found that nearly 70% of new articles are about plastic surgery focused on aesthetic rather than reconstruction. By constantly showing celebrities' transformations, the media reinforces the link between beauty and surgery, turning private choices into public narratives. To conclude, we identified three interconnected changes. The first one is the growing popularity of cosmetic surgery. The second one is the shift in celebrity behavior from secrecy to disclosure. And the third one is a stronger presence of plastic surgery in the media. Together, those three factors, they have contributed to the public acceptance and the promotion of the specialty. So plastic surgery has grown as a specialty with the popularization of aesthetic interventions, a process possibly influenced by changes in behavior of celebrities in unveiling their surgeries publicity. One important limitation of the study is the lack of scientific literature focused on the celebrities and plastic surgeries. In major databases like PubMed, Cielo, and Lilacs, we found only one article addressing this topic. Therefore, we believe that more academic research is needed to better understand this phenomenon and its cultural implications and impacts. These are some of the main resources we use from the analysis. They include scientific studies, media articles, and official reports. Thank you very much for your attention. If you'd like to contact me, here's my email and Instagram account. You can also access the full article through the journal website. And thank you again.
Condition that can often lead people to problems in self-esteem, depression, and social anxiety. But let's begin with my presentation of myself. Who am I? I'm a medical student at IMEPAC, Brazil, and a creative writer. But most of all, I'm a woman in treatment for acne. I have suffered with this condition, and that's what made me believe it is very important that we talk about it. Because if we only consider that we can treat acne, we will forget something very important: the media roles in shaping perceptions. The media shows unrealistic beauty standards that can harm people's self worth. That woman you see is considered one of the most beautiful women in the world, and as you can see, she has flawless skin. Some TV programs, such as True Beauty, on the other side, show the difference between a girl that in the beginning was considered extremely ugly, and the main difference in her appearance when they start considering her extremely pretty is the pimples, the acne she is now hiding with makeup. And how does that affect one's? Well, then we enter in acne emotional too. People start having depression, social anxiety, because their vision of themselves is changed in a way that they believe that just because their skin isn't flawless, they have like a major problem. And of course, acne is not something good. It harms the skin, but it shouldn't be harming their hearts. Clear skin, it's not just cosmetic, it's confidence. When we come to the path of recovery, the dermatological field has many treatments they can choose. Topical, topical treatments such as retinoic acids, salicylic acids are great. But there are other treatments that can help with more severe cases of acne, such as medications. And then we have hormonal medicines, isotretinoin, and other drugs. But there's something that it's many times forgotten, which is therapy. Sometimes addressing acne isn't just by treating the skin, but you also need to provide the emotional support that the patient needs at this time. We need to have a holistic approach to treat the skin and the soul. But we are all already tired of hearing about new ways to treat skin when it comes to products that we pass and stuff like that, and how to use them. We are in a dermatological conference, so let's bring something interesting. We have some novelty in science. Yes, scientists at Pompeu Fabra University in Spain have developed a modified bacterium that can produce a protein called NGAL, which is a mediator of isotretinoin, a medication used to treat acne by inducing the death of the sebocytes. This protein helps regulate both the skin oiliness and treat acne symptoms. This protein doesn't destroy the skin microbiome, which is another positive effect from it. The researchers at the Laboratory of Translational Synthetic Biology in the Department of Medicine and Life Science have already tested the bacterium, Cotibacterium acnes, in skin cells and in mice. So, sooner than we think, we might have new products in the marketing to treat our patients' acne and skin health. Thank you very much. Here we have the reference from the actual research and image uses in the presentations. I appreciate your attention.
Thank you, Dr. Maria. It was truly insightful. Now it's time for
Today I'm going to present my residency research work. The name is Comparison of Effectiveness in Immunotherapy of warts with intralesional interferon alpha 2B versus cryotherapy. Blind and randomized parallel group, clinical and trial.
Hello, Dr.
My only
Melanie.
conflict. Yes.
Sorry for the interrupt. Could you please enable the slideshow mode in the bottom of your screen? Yeah, slideshow mode. Full screen mode, full screen mode.
Full screen, okay. Okay, can you see?
No, doctor. In the bottom of your screen, you can see the full screen mode next to Zoom.
You sure?
Okay, no worries, doctor. You can proceed. Yeah. You may proceed. You may proceed.
Okay, my only conflict of interest is that I worked with a trademark. Okay. We can all know that for the words are the headache, and for many years the people try to find the solution and many treatments for that, but the bad news are that there isn't a solution, 100% effectiveness occur for that, no? And the people trying to find a cure for that. And we can see in this slide alternative for cryotherapy. And this slide we can see alternatives to cryotherapy. For example, BCG, vacuum, PPD, candidal extract, tuberculin, vitamin D3, zinc, echinacea, and others. One of them with 60% with effectiveness, and we can see in this slide. The interferon alpha 2B has many functions. For example, immunomodulators, antiproliferatives, and anti-apoptotics. And we can use that melanoma, warts, CVC carcinoma. We can use squamous carcinoma and other uses. For example, lymphoma and others. And it's a protein that prevents the multiplication of virus and help them of die. When we use the interferon, we have to
Hello, Dr. Melanie.
to be careful with children.
Doctor? Yeah, sorry for the interrupt. Your slides are not moving.
We can see?
No, your slides are not moving, doctor. Could you please check with
Okay.
them?
Okay. Now?
Yeah, it's fine.
Okay. When you can use the interferon, you can be careful with the depression and children, and of course, young people with that. No? And pregnancy and lactancy, however, no direct damage has been reported. And of course, hair failure and transplant and epilepsy and allergy. About side effects, we can see very frequent and are cold, hyperx, pain, weight loss, and headache. We can see the infrequent allergy, necrosis, vascular occlusion syndrome. In this work, we can see that there is very frequent. In this work, we try to compare the effectiveness of intralesional interferon alpha 2B treatment versus cryotherapy in patients with warts at the Darier Hospital in La Paz, Bolivia. This is an analytical, prospective, randomized, and longitudinal study. And it was carried in 2022 and 2023, and our sample was 27 patients. We have inclusion criteria and was patients between 18 and 70 years old, warts between 5 and 10 millimeters, and immunocompetent. And exclusion criteria was allergy, immunosuppressed, severe disease, and pregnancy, lactancy, and children. For that, we use intralesional alpha 2B interferon when of 3 million units adjust to 3,000 units of 0.1 ml at just 5 to 7 applications per patient every 3 weeks. In total, 50 patients, 25 with interferon and 25 with cryotherapy. And what about the results? In the first slide, we have more male patients treated with interferon, about the 60%, and versus cryotherapy, where we have more patients, women. About the second slide, the age in both groups was between 20 and 60 years old. About the number of warts was between 2 and 5, but we have more patients with less number with 2 and 3 millimeters with interferon. About the number of sessions required for the care, we can see that interferon has more number of sessions for cure, 5 or 7 sessions, and the cryotherapy 2 or 3. About the side effects, we can see that the cryotherapy have necrosis, super infection, and of course blisters and pain, of course. And the interferon has pain and necrosis, and the collection of the warts hands, and the effectiveness of intralesional interferon alpha 2 beta. We can see that 20 patients present a cure, and 27 patients present a cure with cryotherapy. And the relapse after treatment present a relapse with interferon with this treatment, and with cryotherapy 12 patients. And we can see these slides with interferon in the first session, in the third session with interferon, and in the fifth session with interferon. Other slide, first session with interferon, and seventh session with interferon. Other patient in the first session with interferon, first session, and in the seventh session. Other patient, third and fifth. Other patient, first, third, and sixth. And for dermatoscopy, the point of necrosis. And failure with biggest warts, third and 10th. With other biggest wart, third and 7th. About the side effects of cryotherapy, we can see the blister. And our conclusion, the effectiveness with intralesional alpha 2B and cryotherapy was similar. 80% with interferon versus 68 for cryotherapy. And the most reported side effects were pain and necrosis. The number of sessions recurred with intralesional was approximately 5 sessions versus 3 sessions with cryotherapy. And I think that it is all. Thank you so much for your attention.
At that time, I didn't have as much gray hair as I have right now, but after this case, I'll explain to you why I developed some gray hair. She presented to me because her gynecologist told her that after an ultrasound and mammogram showed everything is fine on her breast, that he had nothing to do and to come back in 6 months. And now, when she said, okay, nothing to do, this is a rash on my breast. I had previously lumpectomy, part of my tissue removed and followed with radiation 12 years ago. Let me go see the dermatologist. And so she came to me. When I saw that, I was worried about potentially breast cancer or a skin cancer condition. I was thinking of just angiosarcoma, just because of the redness and the rapid spread of angiosarcoma that can sometimes present just as a plain bruise. I took a punch biopsy with her permission, and the punch biopsy was read by the chairman of dermatopathology at Columbia, where I teach, and he was unsure exactly what it is, and he decided to suggest that if I'm worried, to take a bigger biopsy. So what I did was a punch biopsy, a 3-millimeter punch biopsy. And the limitations of that is that you don't have enough tissue when you do that. And for those who do punch biopsies, they know it's kind of like looking through peephole in a door and trying to see the entire room. It may be very difficult. And so I contacted the family and I told them that I'm concerned it could be breast cancer and that we need to go ahead and remove larger tissue and excisional biopsy in the area. The entire family was very upset at me. The husband said, "What are you doing to her? You're stressing her. Why are you doing to her? You don't understand. She's 82 years old. She's already gone through radiation and history of breast cancer. All the studies were negative. Why are you doing it to her?" So I had the husband bother me, who loved me before because I was helping him with another rare condition that he had. Then I had the daughter and the son-in-law all attacking me. My other doctors were saying, "Gosh, you're a dermatologist. Why are you getting involved in it?" And I was not trying to. I suggested they go see their gynecologist, but the gynecologist still refused to do anything because he said, "You know what? I've already done the mammogram. I've done the ultrasound. They show nothing. I'm not going to go ahead and remove anything from her breast tissue." And by this time, I'm wondering why I'm doing it. But the key that we took is not only first not do any harm, but do the best that we can for the patients. And so I still fought on and developed, as I said, a couple of gray hair from the interaction, wondering if I'll be sued. It's a very litigious society here in the United States, unfortunately. I don't know how it is in the countries where you're from. Hopefully, it's not as bad. But here, everybody wants to make money, and they still feel that physicians make lots of money, which is not the case. In any way, she came back to kind of make everybody happy, and I had removed the further tissue, and that further tissue actually showed that she had radiation-induced angiosarcoma. So the options were four, and I'm not going to ask you what you would do. You know already what it is, the diagnosis. But the gynecologist suggested to monitor for 6 months. The other option could have been an ultrasound and mammogram. And some people suggest, well, a more sensitive test would be an MRI. An MRI, unfortunately, at the beginning stages like this would have actually shown just changes consistent with radiation dermatitis, just some thickening of the skin, and would not show anything more. And so a biopsy and an excisional biopsy, a wider biopsy, was the appropriate thing to do. So let's go back to the pathology. The pathology showed that there was positive spindle cell proliferation with a mutation in the CMYC, which is a very typical mutation seen in radiation-induced angiosarcoma. And so the treatment for that is surgical removal. I forwarded her back to the gynecologist who initially did her a lumpectomy. She refused to go there, and she chose to go to NYU in the city, where when she came in, they told her that the doctor actually saved your life, and if you would have waited for the 6 months imaging, you would already be, unfortunately, beyond cure. So what is radiation-induced angiosarcoma? It's a rare aggressive tumor. The first case report was actually in 1936. Can you hear me? Anyway, it was in 1936. It occurs in about 0.3% of post-radiation-induced breast cancer. It may present as a bruise or an indurated plaque, and it's often missed on imaging studies. And the best thing to do is actually to take a biopsy, because histology is the number one. Now, studies have been done to try and analyze the reason why radiation-induced angiosarcoma actually forms after lumpectomy. Is it the dose of the radiation? Is it the frequency of the radiation? Is it the age of the patient? Is it the extent of the area radiated? And the answer is no. And the time duration from the appearance, and this is a table that Sophia was kind enough to do, but again, she's in a different time zone, as I said, and the plan was for it to be presented at 10:30, so it was really her slides and her presentation. But anyway, you can see from 4 years to our case, 12 years, the extent, but it ranges, see here, from 3 to 35 years. And the importance of this range is to have high susceptibility, high level of suspicion, and to tell it to the patient when they are doing the lumpectomy followed by radiation, that if you're going to have a red patch, a bruise, a thickening, a change, you should go to your gynecologist, go to your surgeon. And even if the initial studies are negative, it may be false. So you need to have really high vigilance in this situation. So what we're suggesting here, let me just try and move this out of the way here. What we're suggesting here is the pathophysiology of how this thing actually happens. And if you look over here, you have a healthy cell at the beginning. And that healthy cell, because of radiation exposure in a genetically susceptible individual, will cause DNA damage and then lead to the RIAS, radiation-induced angiosarcoma. What we're recommending is the use of NMN or vitamin B3 nicotinic acid nicotinamide or IV use of NAD in order to reduce the DNA damage and hopefully prevent the mutations that would subsequently lead to the RIAS. And the question is then, what is the science behind our hypothesis? And we've tried to publish this in a couple of journals. Sadly, they did not accept it. But let me review with you quickly why NAD and NMN would be helpful. So NAD, let's see, where are we here? Okay, and we will quote quickly Benjamin Franklin over here. An ounce of prevention is worth a pound of cure. And this is really what we should do in medicine. And so let's go to the next slide. So NAD is a very effective combater of DNA mutation, and it helps in a variety of organs to improve kidney function, heart, lymphatic tissue. It can be stimulated by exercise, by diet, and by supplementation. As a matter of fact, people who are fighting in the UFC competitions take it in order to recover as well. The problem is that with age, the concentration of the NAD declines, and also it gets depleted because our body needs more and more to repair the mutations that occur just by simply living around. Kind of like a car, you have to maintain it, and there's more investment that is needed into it, and NAD is necessary in order to provide that energy. So with age, you can see here, this is the enzyme NAMPT that is responsible to convert the vitamin B3, the nicotinamide, into the NMN, which later becomes the NAD plus that is necessary in order to reduce the oxidative stress, reduce the inflammation, and allow for DNA repair. With age and inflammation, this enzyme is reduced in its efficiency and its function, and therefore the concentration of the downstream metabolites like NMN or NR is reduced, and therefore the final product, the NAD plus, that is necessary in the Krebs cycle in the production of ATP, you can say the currency of the body, is reduced. So what are the lessons of this case? Be vigilant. Don't misjudge. Don't try and push away those cases that present to you and may look like they are nothing or feel like they're normal. Even if imaging studies show that it's okay, that doesn't mean that indeed this is the true diagnosis. Early biopsy, preferably excisional biopsy, is the key. And that we hope that this condition that is rare but extremely deadly can be preventable with the right treatment. Now, where do I get those ideas? I get those ideas from studies that have been used in the past. So in 2015, there was a study published in the New England Journal of Medicine. It was a study from Australia that showed that people with high risk for skin cancer, non-melanoma skin cancer, given nicotinic acid, nicotinamide specifically, vitamin B3 at 500 milligram twice a day, have a reduced risk of 23% in 1 year of the new non-melanoma skin cancer and precancer formation. Other studies followed showing that laryngeal as well as prostate cancer that get the supplementation with the vitamin B3, again, remember it's less potent than the NMN, have not only a more effective response to the radiation, but have less post-radiation sequelae. Now, the reasoning behind it is that when you give the patient the NAD plus, whether it is with vitamin B3, NMN, or IV NAD, you are increasing the oxygenation of the tissue, and therefore you are increasing the oxidative stress on the tumor. The tumor, as we know, protects itself by the Warburg effect using the anaerobic respiration, producing a very inhospitable environment by increasing the lactic acid in the area and therefore reducing the immune system ability to penetrate it, improving the ability of the immune system to penetrate by increasing the oxygenation, because also the production of nitrous oxide, which dilates the blood vessel, increases oxygenation into the tumor cells, improves its sensitivity to the radiation therapy. So combining that while giving the healthy cells the ability to repair themselves gives us both an improved sensitivity to the radiation and a better cure prevention for the radiation-induced angiosarcoma. Now, these are the typical appearances of radiation-induced angiosarcoma, and you can see they come in different shapes and forms, and most of the time they're much less subtle than the one that we caught. And the reason being that people are not having high level of sensitivity to it and are not therefore catching it early. They're presenting to them either because the patient comes late or because the physicians think indeed there was just some trauma and a bruise. Anyway, we wanted to thank you guys for the opportunity to present today. Time to change is our goal. As Sophia said, it's time we learn to act, not react, prevent, not treat. And as Benjamin Franklin said, an ounce of prevention is worth a pound of cure. Thank you very much for the opportunity to present, and thank you for listening. Any questions?
This is Dr. Prakash Kondekar from Mumbai, but at present I'm in
around COVID time, and it is something that will be figuring more and more. I see more and more companies involved in it, which unfortunately has two issues. One is it brings a lot of people who are trying to make money unscrupulously on the hype that is generated by this exosomes, which in the past 20 years were thought to be simply garbage, a byproduct that the body excretes, but are now found to contain the elixir, perhaps, of longevity and life. So again, thank you for the opportunity to share with you our experience, and we're going to present the three case series of patients that have a different type of wound and the use of exosomes to try and heal it. So let's get with the first case. And this is a physician, actually. He's a pain management doctor who had a squamous cell carcinoma on his back. I have the picture of it right now, but it's on my phone, the last picture, which showed that and I can share it here. And you can see that in less than 30 days, the wound is completely healed. And I'm not showing it stretched. It's on my phone in a stretch mode, but it's really reduced in size. Today is the May 27th. And you can see this picture is 21 days afterwards. And you can see it's mostly granulated. There are a couple of wounds over here, superficial, but this was down to the fat. And you can see here it's practically closed. Now, it was really, really large, 8 by 5 centimeters. And of course, I could have closed it by a flap, by a graft. But this doctor is constantly sitting, standing. It will be very, very difficult. And the likelihood of that graft surviving or that flap not dehiscing was very low. Included with that would be the idea that it would be painful and restricting his movement. The interesting thing, and I'll tell you later, what I did not expect is by me simply injecting it intradermally, or in this case, into the fat and the surrounding tissue, I was able to help his back pain. So this pain management guy had a 4 months history of back pain, for which he tried NSAIDs, muscle relaxers, and physical therapy. He did not try steroid injections because he was worried. He was unsure what is this lesion on the back of his thigh. And he said, the funny thing is, and he said it himself, I didn't ask him, I tried all those things, nothing really helped from my back, and yet it got better, not 100%, but around 70% better after you injected me with the exosomes. So the exosomes are extracellular vesicles, and they travel way beyond the area where you inject, which can have positive and potentially other consequences we have to keep in mind as we're learning about those amazing small little particles the size of the COVID virus. So let's understand first wound healing. Wound healing goes through 3 phases that are not really divided. They are all combined together. It goes through the phase of clot formation, then the inflammatory phase, which makes sure that they fight the bacteria, and then the collagen formation, where the fibroblasts produce the collagen, elastic tissue, and try to form the scar tissue again, which actually gets remodeled with it too. Let me just move this. And this is the third phase. Next slide. Okay. So what are the challenges with wound healing? Well, you can have always overgrowth of bacteria in the area. Most commonly is the staphylococcus. So the skin has an acidic mantle. The pH of the skin is around 4.5. When it's wounded, it loses its pH and it becomes a little bit more neutral pH. We know the blood is pH of 7, neutral pH. And when the pH is around 7, bacteria start clinging into it. Even bacteria that are not pathogenic start entering the wound. And you can actually see it in measurements of the pH of the wound. When it gets a little higher, it actually slows the healing process. And so you have to bring the pH down, and you have to make sure that it doesn't get super infected. Other things like oxygenation, the location of the area, the tension on the wound, comorbid condition like diabetes, cardiovascular disease, all those things may contribute to the speed or the slowness of the healing. So let's review a couple of the how can I remove this stuff from me? Okay, I got it. A few of the techniques of wound reconstruction, their pros and the cons. You can do it as a primary closure. It's either intermediate, complex, or just straightforward. And it's a simple thing that you can do. The downtime is usually about a month. You take out the sutures, depending on the location, anywhere from 5 days in a younger person to about 2 weeks on a trunk of an older person. Pros could be that the sutures may speed. A flap is a more complex procedure that you would do that would move the tissue around the area. It requires multiple additional scars that you have to do in order to move the tissue. It's a little more intensive in terms of the technique that you need to know, and the healing time is a little longer, about a month to 6 months. A graft can be either full thickness skin graft, which matches better to the normal area, especially if you take it from that region, or it could be a split thickness, which is very often used for burns. The problem with those things is they do not contain the appendageal structures of the area, and they don't match very well. They contract. They look like a burn scar, like just a thin paper skin that you put on top that does not look good. And they usually also have contractures, so it requires a lot of healing afterwards, physical therapy, massage, maybe steroid injections and things like that. So it's really a lot of downtime. And the problem with that is probably the issue with the remodeling. And then there is secondary intention healing. Now, I do Mohs surgery, which is controlled skin cancer removal, where you examine the tissue edges right away under the microscope and then suture it or allow it to heal by secondary intention. And you saw this gentleman with the 8.2 by 5 centimeter big lesion on the back of his thigh that I allowed to heal by secondary intention. Although with the aid of the exosomes, and you saw how it healed. I saw him today, it looked even better than it looked on the picture when it was 21 days ago, which was a week ago. The secondary intention can heal beautifully, even better than stitches in concave areas. So if you go, for example, in medial canthus, it is a beautiful area to heal. But other places, it will actually cause contracture. It can pull the eyelid down, lead to ectropion, and cause the scarring around joint spaces and reduce mobility. So what can we do to try and speed it up? Well, there's a lot of stuff that has been used. I'm just showing a couple of those things that I've used in the past. I have not used naloxone, although that is also being used right now for speeding of the wound healing. This is just a beta blocker, bimatopros, that can be used as eye drops, but in this case, we're using it to speed the wound healing. Medihoney, because of its antibacterial effects, perhaps some other reasons, it also helps the healing, but it is very, very sticky. They also have it in sheets. Allografts are what you use from substitute for skin, and that is taken from placenta or other forms. It doesn't have any allergy. You have to replace it once a week. The problem with that is in some areas, as I'll show you in one of the cases, it does not hold on and it can fall off, and it's very, very expensive. We're looking, depending on the area, at a cost of around 10,000 per application, sometimes even more. At least that's the cost in the United States. And the way they do it is they dry a certain part of the placenta or other substitute of the skin, and then they give it to you in the sheet. You wet it most of the time and apply it to fit the wound that you have. And it has some growth factors as well on it that allows the wound to heal. Then you cover it, and the person cannot wet the area for an entire week. The other issue with that is sometimes they get super infected, and unfortunately that has happened with some of my patients as well, and you have to replace it. Regronex gel, I've been using it a lot, very expensive. As a matter of fact, one of the patients that I recently saw said that he had to pay $1,700 in the US to get it. The insurance did not cover it. Although when insurance covers it, although it's still a burden on our economy, it could be a copay of $30 or so. Hyperbaric oxygen, well, multiple sessions are required for that. It definitely works. It speeds the healing time, but people who are claustrophobic cannot really utilize it. And I've tried for some people, and they simply said, forget about it. The other thing is it can cause some popping in the ears, a lot of compression. It's kind of like going into a chamber where you underwater. And so you can feel the compression in the ear, and you have to slowly increase the pressure, usually to about 2 atmospheric pressures, and you have to go 5 to 4 times per week for a period of 2 months for the area to heal. So we're going to talk now about exosomes. And exosomes are non-immunogenic, fast-acting, and you can use them either as injection, application, IV. You can drop it into the mouth through droplets, or massage it into the area. And this is really the key for the regenerative medicine nowadays. So let's look quickly at the structure. It's a lipid bilayer structure, and that's very important. Why? Because we talked about the pH of the wound. If the pH of the wound is going to be too acidic or too basic, it will go ahead and destroy this beautiful lipid bilayer, which is very sensitive. And while it can handle lower pH of about 4.5 or so, lower pHs than that will destroy the cell wall and prevent its ability to use those special receptors. Do you see my arrow? Okay, I don't know if you can see my arrow.
Yeah,
You can see the arrow. It will prevent those receptors from being present on the cell wall and therefore docking in the area that they need to be docking to. So this will just be like applying Regronex gel, which is only the platelet-derived growth factor beta, as opposed to all the other growth factors that I'll show you shortly and that Sophia prepared for you to see. So let's go to the next area. Where is the best exosome being taken from, and what are they utilized for? Well, the richest and most productive region to get the exosomes, and we call them H0, and that's the company that I personally use. I do not work for them. I have no personal, what they call, benefit from it, is the Wharton jelly, which surrounds the blood vessels, the umbilical vein, as you can see over here, and the 2 arteries. And that area is really the highest concentration of the mesenchymal stem cell derived exosomes. And so this area is harvested, centrifuged, and the cells are collected from that area, and the size is very important also. The size is about the COVID virus size, 50 to 150 microns, and they are then conserved without any antibiotics, without any added factors into it, in a special minus 196 degrees. So it's like liquid nitrogen, special huge canisters, and there it can be stored for years, 2, sometimes more years. I personally store it in a minus 40 degrees because I do not have the ability to store it in a liquid nitrogen. You would need huge storage for that. So it can lead to stem cells. Stem cells obviously can lead to bone, adipose tissue, nerve regeneration, cardiac regeneration. And so, as I said, exosomes truly are the future of medicine. Learning how to control where they go, what they produce, will be our next stage. And perhaps even now they're working on trying to use those as little messengers that would carry immunotherapy or chemotherapy into the tumor by using them as a docking to dock and be internalized by the cells that you want to either heal or kill. Exosomes are usually found in MVBs, which are the large vesicle you can see over here, which contains many of them. And this basically shows how it contains all the different parts in it, the different growth factors that then later invaginate and are released into the cytosol, into the surrounding tissue. And using those little honing factors, they would be pulled into or attracted to wherever the inflammation, wherever they sense there is an SOS signal that would need their assistance. And this is the different growth factors that are found in the exosomes. And there are many of them. This is just some of the growth factors specifically found in the mesenchymal stem cell derived exosomes taken from the Wharton jelly of the umbilical cord. And you can see here VEGF, TGF beta, all of them reduce inflammation. They reduce scarring by its anti-fibrotic effect, stimulate fibroblast proliferation, angiogenesis, which we know is really important for bringing in the nutrition and oxygenation, reduce the scar, as it says, it modulates scarless healing, and a lot of anti-inflammatory. And again, these are multiple molecules over here. Now, you'll see a lot of stem cells as you go to different conferences that would be sold and advertised. There will be stem cells taken from fat, from bone, from the person themselves. The issue with the stem cells that are taken from adult tissue, as you can see here on my right, is that just like those or adipose tissue, is that they're already aged and they do not have all the growth factors that you would have in the age 0, exosomes. And so they're not at their peak performance. Just like if I would run right now a marathon, or I would run it when I was 16, it will be a different marathon for both of us. I wish I could run it like I did when I was 16. But the idea is our performance is not as good. And sadly, even our stem cells will not produce as good an exosome. Even though they can produce it, they will not be as effective. So this is the effect. It has lower fibrinogen, fewer angiogenic factors, and fewer immune-regulated proteins. And this shows the mechanism of action, how when it's released from the stem cells, mesenchymal stem cells, this is the exosomes over here, and this is a large image of the exosomes. It basically changes the inflammatory conditions. So M1 macrophages are the ones that are stimulated or released during infection and wound healing. they cause inflammation, and inflammation actually slows the healing. We want to reduce the inflammation because we can control and avoid infection. We want to have the right pH for it to heal well. Also, the other thing it does is increases vasculature, more blood supply, better nutrition, better oxygenation, faster healing. And also it helps the proliferation and the migration of the necessary cells, helping to remodel the extracellular matrix, the ECM. And you can see this is the idea of the wound healing, that it would promote the exosomes. So let me share with you some of the cases. This lovely young lady was one of the first cases that I used exosomes on injection-wise on a patient. She came from the emergency room all in panic after a can of condensed milk exploded in her face. She went to the ER. They provided her with silvadins, silver sulfadiazine, which is unfortunately the common treatment in the ER. In my opinion, it's already outdated and not the best option for treatment. There's so many better treatment options. But anyway, it's antiseptic. Unfortunately, it also dries the wound and it's not optimal for wound healing. She came to me all scared. This was a second-degree burn on her forehead, glabella, and you don't see it here, also on her nose and her eye. And after 5 days, even though she's dark-skinned patient, it healed without any marks. It's a little dark picture. There's a little light on her nose. Where's my arrow here? I don't know where's my arrow. Anyway, yeah, a little light on her, but this area over here and the rest of the nose cleared without post-inflammatory hyperpigmentation, which is remarkable. And I used twice injections, one after the other, and she came to me to show the results, which she was ecstatic, and afterwards ended up sending other patients. This was a next patient that I had, and she came 10 days. She's actually a nurse. She came 10 days after a blistering burn from spilled boiled water. And you can see here, this is deep dermis. You can see this is the reticular dermis where my arrow is, and the rest is the papillary dermis where it's a little more red. So this is why it almost looks like fat, but it's not fat. It's the reticular dermis. And around it, you can see the sloughing skin, which is black, and that's where the blisters came off, and the skin is still burnt, but it's still on top of it. I injected her with 400 billion exosomes, and you can see 1 day after that, she's already granulating. It looks much, much better. Look at the color here in the difference. It's starting to shrink. 9 days afterwards is like, wait, completely healed? Yeah, it looks like it's practically completely healed. There are some areas here that maybe if you zoom in, you could see that it's a papillary dermis. You can show them that there's a little papillary dermis still healing, granulating. Well, this is, about a little over 2 weeks afterwards, completely healed, a little bit hypopigmentation, a little bit loss of color in the area. And this is a little bit area of hyperpigmentation. Sorry, guys, I'll be with the patient shortly. And this is how she came 6 months afterwards for us. Now, of course, we can do some lasers to help bring down the brown, but the issue is she does not have any scarring contraction. There is no itching. There is no keloid formation. The color is pretty good. The healing time is very, very rapid. And there is no need for sutures. There's no need for additional scars, taking split thickness graft or buying some expensive $15,000 skin graft, allograft, and applying on the area. So again, this is H0 exosomes, the beauty of them. Patient number 3 is actually a Mohs patient that I had. And that patient presented to me with a big skin cancer on her scalp. She originally comes from the Soviet Union and was not directly in the path of the Chernobyl fallout radiation, but I see a lot of those cases with very weird, strange, large skin cancers. And I do believe that the fallout is related to that, because in May, there is a big parade that they always do for the Victory Day against the Nazis. Is it May 9th or when is it? May 9th, yes. And they all were forced to go outside and parade. So even in Moscow, when they went to parade, there was some rain and they didn't realize the rain contained fallout. And the fallout, I've seen patients, multiple of them, who have skin cancer, specifically on their scalp, even not so much on their body as much as on their scalp. And I do believe it's related to the uranium causing chronic inflammation and 20 years down the line leading to skin cancer. But anyway, that's something that needs to be proven, can be proven, but I'm having difficulty finding people who would be willing to look through the pathology just like they look through fossils and try and look at the different products that are in it, like the uranium. So this is a large wound. And here I'm showing you to her because we decided initially to put a skin substitute graft. And you can see here, she's got the skin graft in that area. And she came in and it already fell off. This is when she got the skin graft, it fell off. And the dressing that she had on the area fell off because she, it wouldn't stay on the scalp. It's easy to understand there's a lot of hair and it has to stay there for a week. It's very, very tough. I mean, you move your head in sleep, even not in sleep, and you just move your head and it starts gliding down. It's very difficult to keep the dressing tight on that area. So what we did here, this is just some Sylvidin around the area to prevent the loss of the exosomes when we inject it. We put first a little bit of Vashi, which is hypochlorous acid, to apply on that area, which has a little bit higher pH. We use saline afterwards to neutralize it, to make sure that the pH is more around neutral pH so that the exosomes will work more effectively. And then we inject the exosomes intradermally. And this is, you can see 3 days after the injection, you can already see it's shrunk. This is 7 days after, and you can see it's already granulated from an area where there is an area here to the fascia, fat, dermis. There's actually no dermis in here, but fascia and fat, it starts already to be already dermis. And here the fascia completely healed, and most of the area is granulating with nice dermis. Still some areas of black because she was on blood thinners, and so we had to cauterize extensively, which means lack of blood supply and also impedance of healing. So you can imagine without it would have been even worse. And here you can see her 9 days afterwards. This is absolutely remarkable. I mean, when I saw that, my jaw dropped. This was remarkable. The other thing was we were wondering, will we get some of the appendigeal structures back? Because if we put a graft, this entire 5.2 by 4.7 centimeter would be a hairless area. Hairless area. Yeah, you can cover it with longer hair, but with age, as we know, everybody suffers from some hair loss, and this will be aesthetically definitely not pleasing for anyone. So this is the next, this is again showing you for comparison her before, and this is the second day after her fifth and last injection. I decided not to inject anymore and see how it will continue to heal just from that. And this is, you see April 1st, and this is April, I think it says 23rd here. Yes, 23rd. And let's look at the next slide. And this is May 21st. So this is about 7 weeks after the graft fell off the scalp, and you can see the hair is in that area. The entire wound shrunk very, very nicely, and it shrinks. The strange thing is, look at the shape that it forms. It contracts based on what mobility the body has. We're just using here a Q-tip to move the hair out of the way because it's already covering it so well. So if I would have done a flap on that area, the scar tissue would have led to hair loss. The area would be with significant amount of pain. Most likely it would have anyway had areas of dehiscence and require secondary intention healing. The downtime, the wound care, it would be really, really not something that I would look forward to as a patient to go through. And we always have to think of ourselves as we treat, as physicians, our patients, what would we want done to ourselves, right? So anyway, I think the future is here. The future is exciting. And as Yuval Raphael's song prays, may hope, unity, and peace bless our world. And with that, may we all wish and hope for a new day to come. A new day will rise, like the name of her song. And thank you so very much for listening and for giving me the honor and opportunity to be with you guys, even virtually here today, and to present it. Thank you. Any questions?
Yes, I have. You're talking
Yes.
about the maintaining the pH.
industry, I'm going to present to you a clinical study which assesses deodorant efficacy, safety, and reduction in axilla, hyperpigmentation, and skin undertone. Next slide, please. Can I control it from my end? Okay. So I'm going to go to the basics. Sweat causes malodor. It's unpleasant. It impacts your self-confidence. It's not socially acceptable to be smelly. And you're, of course, told that you have poor hygiene. Olfactory senses detect body odor, and deodorants for use in the axilla primarily combat malodor. So at first, when deodorant world started, it was just for the axilla region. Today, we have whole body deodorants, which are newer products which are targeting all body parts, including the armpits, the feet, the genitalia, just name it, and they're all there. It's out in the market. With more products being introduced, efficacy and safety is very important. Deodorants help counteract the smell that's produced after sweat, after we sweat, and it's broken down by bacteria in our armpits and other body areas, and that is what the smell is. That's how the smell is produced. That's called malodor. So there are ingredients in deodorants that modify these conditions in the underarms without any feast. The bacteria feast on the proteins and the fats that are delivered in the sweat. And if there's no bacteria, that means there'll be no smell because there's nothing to break it down. So deodorant is a substance that's applied to the body to prevent or mask the body odor. And regulatory bodies like federal, FDA in the US or Health Canada in Canada, where I belong, depending on the ingredients, classify them as most deodorants as cosmetics. Next slide, please. The global deodorant market size was valued at $25.6 billion in 2023 and is projected to be around $227 billion in 2024, which was. And by 2032, it should reach $42.5 billion. And Europe has dominated the deodorant work with a market share of 34.71% in 2023. And now, which form of deodorant is more acceptable? The sprays, which you see 50.90% have really taken on. Next is the roll-ons, and then the stick deodorants, which were a thing of the past now, but are still, doing okay. And then there are other kinds, powders and soaps and so on and so forth, which are being introduced. Next slide, please. So let's go to the basics. The sweat glands. We have two types of sweat glands: acrine glands, which are found over the entire body at birth and produce sweat, composed of water and ions only. And then there are the apocrine glands, which are associated with hair follicles. They develop at puberty in specific areas like the underarms, the mammary areolas, the scalp, and the pubic region. So, as I said, sweat is rich in fatty acids, lipids, and hormones. And malodor is also caused by as I said, it's the sweat that's broken down by the bacteria. And there are certain species that stand out, like the Staphylococcus, the Cutibacteria, the Corynebacterium. And then also lately, they have seen that gram-positive anaerobic cocci, like the Anaerococcus and Petanophilus species, have also been associated with this breakdown of the sweat. And I've given you the reference there. If anybody's interested, can look it up. Next slide, please. So as I said, there are two types of glands. There's the acrine gland and there is the apocrine gland. So we are mostly focused on the apocrine gland because that's what we get when we, reach puberty, and those are the glands that produce the most sweat. Next slide, please. So let's talk about what the conventional deodorants are out there and what are the ingredients that these have. So most, deodorants came from the antimicrobial world. The ingredients were from the antimicrobial world so that they could kill the microbes. Then there are odor maskers, which just mask the odor, purely mask the odor. Then there are odor absorbers, which again, they absorb the odor. That way you cannot smell bad. And these days there are alternatives like bacterial extracts. Plant extracts have joined the bandwagon. There's essential oils. And then there's lots of synthetic compounds which are being now introduced. Next slide, please. So the objective of the study of this, so I come from a clinical trials world. So the objective of the study the clinical trial was to evaluate the deodorant efficacy, safety, and reduction in axilla, hyperpigmentation, and skin undertone. Next slide. So there was a randomized blinded clinical study lasting 12 days in healthy volunteers, 18 to 67 years of age, for testing of deodorant products. And usually the subject size for this kind of clinical trial is 30 in one group. So 30 subjects in a group. Our clinical design involved human sensorial assessment methods and safety assessment, including visual assessments by expert graders and a collection of adverse events. Next slide. So subjects had to abstain from using of any antiperspirants, deodorants, perfumes, colognes, powders, medicated shampoos. Those were the exclusion criteria for the study. Antibiotics, antibacterial, or any cosmetics in the axilla for 10 days prior to the study. Only the provided unscented body wash was to be used for their washing needs or personal hygiene. And then they had to shave. There was strict criteria of shaving 3 days before a study and not during the study. They're not allowed to smoke 2 hours before the study because it does, cause a problem in sweat collection. They had to abide by strict study restrictions of what to eat and what not to. For example, spicy foods were out, garlic and onion was out. There were restrictions on that. And then 10 days prior to the study, this diet had to be followed 10 days prior to the test phase for its entire duration of the study. Subjects were selected in a random and unbiased manner as per study considerations, and they should have people who had a recognizable body odor level had to be. There was certain criteria, and I'll come to that later. That how much the odor should be before they get onto a study, because some people don't smell naturally, or the odor is very low. So low body odor subjects or those with high body are not selected because those would be outliers. So there should not be a difference between the right and the left axilla smell. It would be not more than 2 on a 10-point scale, because then it would not be enrolled in a study if one axilla smells more than the other. So there had to be a certain rule that had to be followed. Next slide, please. Again, during the study, no fragrant substances like perfumes, aftershave, lotions, or bath oils or body or hairsprays were allowed. T-shirts that the subjects wore, had to be laundered following a uniform lab procedure. It cannot be, it has to be uniform. It cannot be otherwise, because people, even our laundry detergents these days come with smells and perfumes and so on and so forth. And that would just, mask this body odor then. So those T-shirts were washed in the lab itself, it is following a certain procedure and using a certain kind of deodorant, which was devoid of any smells or any perfumes. And they all were done at the same time. The physical exertion also, like jogging or tennis, was not allowed. No breath mints took place, mouth rinses, sprays, chewing gums, coffee, or tea at least 2 hours before evaluation, and no alcohol 24 hours before an evaluation for these subjects. No washing of axilla at home for the duration of the study. Axilla washing was done in the lab itself. Next slide, please. So the deodorant efficacy design involved a 12-day trial with controlled washes at day -1, day 1 to 10, and then T-shirts were provided to be worn by subjects at days 1, 10 for 24-hour wear, and day 11 for 48-hour wear, following controlled washes in the lab. Expert visual evaluations for the axilla were carried out on day 1, days 2 to 9, 11, and 12. And this is routine for a deodorant study. Washing axilla for 10 seconds. So when the subjects walked in, the axillas had to be washed for 10 seconds with one soapy towel, so which was like a bounty towel or a paper towel, which is a thicker towel that holds, it doesn't, get all white paper. It doesn't. It stays as a strong towel, and that's what it's called a bounty towel in here, but there can be other options in other countries. That's what we wash the axilla with 10 seconds, and with a soapy towel, we rinse thoroughly and dispose the towel with warm water until all visible signs of soap are removed for 20 seconds. So these 10-second, 20-second durations matter because you are otherwise going to affect the design of the study. So there were strict timers are on, and you have to follow stopwatches and so on. And then the axilla is gently patted with clean, dry, disposable paper towel, and then a folded dry towel is placed in the axilla, both axillas under the product before the product application step. So next slide, please. So these are the two scales that were used. One is called the malodor scale, with which the expert judge, grades these subjects, and then there's the off odor notation, which are followed, in cases where baseline where you have a strong smell coming from a subject, or it's off odor, you can tell that the subject has not followed the rules, has probably eaten garlic, let's say, or an onion, and the judges, which are trained for over 25 years, these are odor judges, and very highly paid and respected in the industry. These are the judges who conduct these studies and can distinguish, have a very sharp nose, to make out this the smoke from a perfume, from alcohol, from soap, or for onion, garlic, and so on. So these are trained, personnel that are used on a study. Next slide, please. So odor assessors are in an isolated evaluation station. So imagine a large room with several stations with curtains, so a subject with two pads, the same bounty towels under their arms, folded under their arms, walk up to an assessor, and then they lift the left arm first. As soon as they reach the assessor, their hands are down, that they reach, there's a technique of doing it. They raise the left arm, the assessor smells the left arm, writes the score. The subject puts his arm down, and then the next arm is raised. And this is what is followed till all the judges, there are about 4 or 6 on the study who give individual evaluations for these, and then they are all, checked together if they all match or not. So this is the basic design of a deodorant study. I'm going to go, next slide, please. So the test articles used were a solid deodorant, a cream deodorant, a solid bar deodorant, and a body wash deodorant. So we're going to move on. These are just the test articles that were used on the study. So 4 test articles were tested. Next slide, please. So now that you've applied, there are certain ways of applying, whether it's whether it's a spray, whether it's a solid, there are different ways of applying it. If it's a spray, you stand 6 inches away from the subject, you aim your can, at the axilla itself, and you spray for 2 seconds. So every solid is different. You put 0.02 grams, then it's weighed before and after, and you have to get exactly 0.02 grams in the axilla. So that's how the weight is always the issue in these. You have to stick to strict guidelines of how you have to, spray or use a wash or a cream, as far as the amounts go. And this is the irritation grading, which the expert grader would check every day, so that there is no irritation of any sort in the axilla. And this is the underarm scale that they would be using. And when they checked that, they did not get any, there was no irritation with any of the 4 test articles that we tested. Next slide, please. And no adverse events were reported. I think you're missing some of the slides. Can I just go to the 19th and 20th? Because it's not going in order of what I sent. So these are this is the hyperpigmentation design. So this is, so you would check, you would basically use the product and then check, for the hyperpigmentation. Professional photography was done. There's an instrument called the colorimeter with which you assess the redness, of any skin portion, whether it's axilla or anywhere else. But in this case, it was the axilla, and then you would also collect adverse events over a period of time in the clinical trial. Next slide, please. So this is the grading for the axilla. So as you move on, so if it's 0, it's very clear skin, no visible pigmentation, dark sunspots, and even for skin tone evenness, 0 is good. And as we move up towards 9 or 10, this is a 10-point scale, a published 10-point scale, so you can see the difference there. This is the colorimeter. As I said, we tested with the colorimeter, so the armpits were checked, and you saw that at week 12, the color L, which is the brightness of the skin, it increased. That means that hyperpigmentation was going down, and the skin was getting brighter with the treatment that it was given. Next slide, please. With the cream also, we saw the same effect. These were just, couriers. The cream or the solid was just a courier for the ingredient that was which was the same ingredient. So even here, you can see that there is a difference between baseline and week 12, and there was improvement in the brightness even with the cream. Next slide, please. Next slide. This is the skin discoloration with for the hyperpigmentation, which was checked. And at baseline, you can see that the hyperpigmentation was at 5.37, and then it decreased to 3.69. So there was quite an improvement in all about 35 to 33 subjects that we tested. Next slide. And so was the discoloration again. The skin undertone or the hyperpigmentation, again with the cream, showed the same effect, a positive effect that it was improving over a 12-week period. Next slide, please. And the body wash also, to a lesser extent, but again, it showed improvement because I guess the ingredients were the same. So it was just a courier. The client wanted to see which mode of providing this antiperspirant would be better. Next slide, please. And here's the skin tone evenness with the bar, with the cream, and with the wash. Again, all had a similar trend that at 12 weeks, skin tone evenness was better for all of them. Next slide. And here is some clinical photography, that you can see the improvement. So this is at baseline. Then you can see the second picture slightly improved. Third picture and the fourth picture, there's a lot of improvement in the clinical photography itself, which is proof that this product worked. Because with antiperspirants, it seems that there's people get a lot of pigmentation. And so that was what this product was meant to solve, that hyperpigmentation. Deodorant, it should smell good, make people smell good, mask the odor, and yet it should improve, not cause any, hyperpigmentation, the axilla. So again, here you can see that this was a darker skin and brightness in the axilla at the end of 12 weeks. Yes. So what did we see in this study? We found that the whole body deodorant that was tested showed effectiveness in combating axilla odor. It also exhibited minimal irritation potential, and there was good product acceptability. That was a chart that we skipped. There was a whole questionnaire that was put to subjects that's included in here. You will find it that subjects were asked different questions like, did you like it? Did it reduce the smell that in the axilla? Did it create better? Did it improve your hyperpigmentation? And there was the skin brighter, and the answers that they provided based on that. These are called self-perception questionnaires. Based on that, it can be said that there was good product acceptability. Expert visual grading showed statistical significant decreases in appearance of hyperpigmentation and skin tone. Colorimeter, which I said is brightness, which is an instrument very widely used in the skin industry. Values also showed lightness and brightness, which is improvement over the time points tested. And then B values, which is again a marker of redness, showed decrease, which is a good sign because redness went down. So professional photography, I showed those results, also further confirmed these results. In conclusion, the product tested proved to be efficacious, safe while reducing sweat odor, axilla hyperpigmentation, and skin undertone. And this provides a backup for product claims, adds values for consumers, helps clients in maintaining a competitive edge. Next slide. And so the conclusion is that the products tested proved to be efficacious and safe in reducing sweat odor, axilla hyperpigmentation, and in improving skin undertone. So with that, I want to thank you, my co-workers first, who worked with me on the study, Mary Driven, Joanne Brown, Lisa Long, and then of course you, the audience, who listened to this presentation that gave me, and also the organizers who let me present at this forum. Thank you again. And any questions, I'm here, or you can contact me by email. Thank you.
Can I have one question?
Go ahead.
Yeah, Dr. Nalini, it was a wonderful presentation, and
in vitiligo are common socially significant dermatoses, affect exposed skin areas, causing emotional and social discomfort. Both are multifactorial diseases with complex pathogenesis. Trace element imbalance affects psychological process and the skin health. Next, please. To identify similarities and the differences in essential trace element changes in patients with psoriasis and vitiligo. We have examined 123 patients, of them 52 men and 71 women, aged from 18 to 65, and clinical and lab exams conducted. Hair samples analyzed for zinc, iron, copper, iodine, manganese, selenium, chromium, and cobalt, and the neutron activation methods. And the result, gender clinical forms, we have examined psoriasis, 62% of women and 38% men, vitiligo 64% of men and 36% of women. Psoriasis forms is vulgar 89%, palmoplantar 11%, arthritis 12%, and erythroderma 8%. Vitiligo forms acrofacial 45%, segmental 32%, focal 11%, vulgar 7%, and the setons 5%. Next is result trace elements analysis. We have identified chromium and the copper levels significantly reduced in both disease. Psoriasis showed lower copper 7.597 milligrams per gram, and the vitiligo 12.65 milligrams per gram. Iodine elevated in psoriasis, normal in vitiligo. And selenium at lower reference limit in psoriasis, slightly lower in vitiligo. Manganese elevated in vitiligo, cobalt reduced in psoriasis. And iron normal but low range in both groups. In conclusion, trace element balance in vital in metabolic and dermatological process. Imbalance can contribute to pathology development. Further research needed to clarify the role of bioelement imbalance in skin disease. Thank you.
Thank you so much, Dr. Gulash. It was an insightful presentation. Are there any questions from participant side?
diet, because I'm using food as a medicine, and that's what I believe, because I did my homeopathy, I did my Ayurveda. Last 35 years, I am practicing naturopathy as a particularly for any type of problem, health problem. Yeah. So today we'll talk about the skin problems. Acne vulgar. This refers to the pimples, blackheads, or just acne. It is a common skin condition that occurs when hair follicles become blocked with dead skin cells. This is particularly important because dead skin cells, they are the reasons, or they are the problems which acne vulgaris has a base. So one can notice one or more following symptoms: whiteheads, blackheads, tender red bumps called papules or pustules, painful lumps. Particularly the youngsters, they have this problem, but it is not only restricted to the youngsters, but even in some other adult cases also, they have this problem. And about more than 50 million people in the world, they are affected with this problem at given time. It is common in teens, actually. Next. So acne refers to a variety of blemishes caused by the blockage of pores by dead skin cells and sebum. Breakouts may involve one or several different types of acne vulgaris. This can be type of vulgaris as below. The whiteheads, a common inflammatory blemish known as close come down. Whiteheads look like small raised white or skin-colored bumps. They occur when skin cells and oils block a pore but remain below the skin. Here, the problem comes when the diet is very much with the use of oils and excess oils, and because of that, this problem occurs. The next is blackheads, or an open come down from when the skin cells and oil emerges through the pore. That excess of oil, what is available, and that has been coming out. That is, body naturally throws it out, and that is the reason these blackheads, after the accumulation of those oils, drops at this skin level. Next. So pustules are simple occur when bacteria within the blocked pore causes an infection manifesting with pus and inflammation. And when this pus formation is there, usually the person trying to remove the pus with hand, that is maybe by pressing the place, and that is not advisable, because if it is there, then scars will be remaining. So one has to take care that it goes out naturally. The papules are inflamed, but without pus, papules can often progress to pustules, because if care has not been taken, then this happens. Then nodular acne, the form of severe acne that causes larger bumps. They are known as nodules. They are hard, inflamed, and painful to touch. A pocket of pus lies far beneath the surface of the skin. So it is difficult to remove those skins even surgically. But if it is done naturally, they come out, and the excess, that toxin part, we can say it is removed naturally with the help of diet and body detox. Then cystic acne are modular acne in which nodule is not only larger but softer due to the expansion of pus closer to the surface of the skin. Nowadays, it is known as severe nodular acne. Next. It is always embarrassing. So next part is psoriasis. The acne, we have seen how we can deal with that. So it is always embarrassing to scratch own skin in front of many others. A long-lasting, non-contagious autoimmune disease characterized by patches of abnormal skin is known as psoriasis. So in this case, particularly toxins in the body are very much there, and try to remove those toxins with the help of hydrotherapy in various forms, because water in the three forms is available: solid, liquid, and gas, and we try to use it for body detox in all the three forms. And there, because of the body detox, the treatment for the psoriasis starts along with other type of diet. Let us go further. These areas are red, pink, or purple, dry, itchy, and scaly. Psoriasis varies in severity from small localized patches to complete body coverage. Injury to the skin can trigger psoriasis skin changes, and that's particular spot, which is known as the Koebner phenomena. This makes skin build up into bumpy patches. So at this stage, it is important to have the treatment. Otherwise, this happens that bumpy patches will occur. They can grow anywhere, but mostly appear on the scalp, elbows, knees, and lower back. On medium skin tones, the plaque may be coral or salmon colored, and these scales are silvery white. On darker skin tones, plaque may be dark brown or purplish. They gray scales. These plaques may be itchy, painful, and they sometimes crack and bleed. So at this stage, it is important to apply sometimes the external things like maybe natural ointments made out of some of the natural things like neem, that is the one of the treatment we give it in the form of decoction of neem leaves. In serious cases, the plaques will grow and merge, covering large areas. People with psoriasis can also get type of arthritis. So this is again a difficult stage, particularly for that person, because psoriatic arthritis is very, very painful and causes swelling in the joints. So when it starts, the indications are there, then that time, seriously, treatment has to be undergone by the patient. Because it has something to do with the immune system, it is an internal disease, even though it appears on the outside of the body. So here, body detox for in our patients, we did at least for 7 to 8 days continuously with the help of the water, that is hydrotherapy. And there it could control the further damage to the joints, or particularly the painful area. Next. So how stress and acne are linked. Some people get acne when they are stressed, overwork, or sleep deprived. When this happens, the body produces hormone called cortisol. So this can increase blood sugar and provoke whole body inflammation, and inflammation in turn increases the production of sebum. So this is also one of the factors which is taken care of during treatment for the psoriasis. And simultaneously, some of the treatments like sun bath, in some cases, that is natural sunlight is useful. And along with that, mud therapy, that is the particularly type of soil is used for treatment on that part externally. Next. So diet is very important, as I was telling. Despite considerable debates, some researchers believe that there is a link between the food a person eats and their risk of acne breakouts. Regularly eating glycemic index food, that is high glycemic index food, is thought by some to promote acne, because glycemic index indirectly and directly has effect on psoriasis and other type of disease, skin disease also. So these foods raise blood sugar, causing inflammation, and the increased production of sebum processed food, particularly sugary foods, starchy foods like white bread, potatoes, white rice are examples of high GI foods. So these foods try to be eliminated or restricted in the diet so that body detox can get benefit, particularly for controlling the psoriasis and other type of skin problems. Next. So skincare, certain skincare products can contribute to acne by blocking pores or stripping away oils that block bacteria from entering follicles. Skincare products like alcohol-based toners, astringents, exfoliant, oil-based cosmetics, thick skin cream, and moisturizers, hard soap, and cleansers, they are to be, as far as possible, restricted during this treatment. So the improvement of the skin and the eliminating of the toxins helps. Does dirty skin cause acne? Dirty skin does not cause acne but can contribute to the breakouts by increasing the risk of bacterial exposure. On the flip side, over-cleaning the skin can lead to dryness, which can trigger the overproduction of the sebum and an outbreak of the acne. So here also, if one can see that the excess of dryness, if it is there, during that period particularly, we use neem oil, which is a natural oil available, and that could help to reduce the dryness, even using it externally and internally, both ways, and that helps to control the problem, particularly acne or psoriasis. Next. Next slide, please. So from birth to death, the skin, the risk of illness and disease is always present. But if we have safe and nutritious food, the risk is less. In this case, the body detox, the safe and nutritious food, which can complement the body healing, particularly in case of acne or psoriasis. Next. So food is a substance that can be consumed, metabolized, and assimilated by an organism to produce energy, stimulate growth, and maintain life. It consists of carbohydrates, proteins, fats, vitamins, minerals, and water. So during this treatment, the carbs have the restriction during this treatment. Proteins and vitamins, they are working wonderfully, and fats also have to be controlled in the diet. Then particularly the fruits like papaya, which contains this pepin as a enzyme, then carotene, that is also available in carrot. So these type of foods are orange color food, even oranges, if they are taken by the particular person, they help the healing process. Next. So fitness, health starts with individual cells of our body. If our cells are healthy, so are we. Healthy cells in turn depends upon the continued faultless replication of our DNA, because it is not everything that we can do with the help of diet and body detox, but sometimes it also has support from the particularly DNA of that person. So the it is not possible to have a change in that, but restrictions on food, restrictions on particular toxic food, and having the body detox works wonderfully, particularly for the improving the skin problems and overall health also. Here, the pranayama works wonderfully because stress also has a factor in the particularly skin ailments like acne and psoriasis. So the pranayama works along with the other things like diet and body detox. Next. So in my experience of 30 plus years of practice, that the internal use of detoxin and external use of leaves, paste particularly, work wonderfully post-body detox treatment. In the treatment of dermatitis, body detox with few of the yogasanas or pranayama will work fruitfully. Thus, these are the few of the common methods which are being used for my many years traditionally, including by me for my patients with many skin and other health problems, along with natural diet. I can actually I would have added those pictures, but because of the shortage of time, I do not show those pictures because some of the patients, they had the problems, particularly psoriasis, for more than 10 years or so, and they were trying earlier the other allopathic treatments, but they could not got help from those treatments. So ultimately they came to me and got benefit. But in naturopathy, because the body detox take time, because the person is coming with the help of allopathic treatment, they say, and have lot many toxins accumulated in their body. So trying to get rid of those toxins from the body with the help of hydrotherapy takes little time, and that's what in naturopathy the treatments take a little more time, and that is one of the drawback of naturopathy, I can say. But that is the limitation. But still, it works if the patient have the patience, then it gets recovered and they can get rid of their problem. Next. Next, please. Yes, next, please. These are some of my other, even American Institute for Cancer Research, they had invited me in Washington, D.C. for particularly for the diet and nutrition for the cancer. Next. Yeah, next. Next. Yeah, there are many types of cancer, and particularly sometimes these, if the care has not been taken, some of the small skin problems could become the cancerous things, and that is the precaution one has to take. Next. Yeah, this was also next. So this is my book, Food is Your Medicine, and it has been working for long many years. Next. Yeah, next. 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 Because I have been traveling to many countries for giving my problem. This is the Bielefeld in Germany. Next. Next, please. Yeah, this is USA. Before that, it was also in Germany, where I had suggested particularly natural diet as a general diet, and they were appreciated that. Yeah, this is the 2007 one of my program in USA. Next. Yeah, this is my Frankfurt program, Germany. Next. Yeah, this is also benefit during the, this is stress management particularly works wonderfully. This was in UK in 2001, and many of those participants, some of them were having some skin problems. They could get benefit subsequently because after finishing the program, they could get benefit after 1 month or so, because I have been giving advice to them about the diet and nutrition and the pranayama. Next. This is the Naturopathy Center in Mumbai, in India. And we have been naturopathy is an art and science of non-invasive healthcare and health assessment in which neither surgery nor drugs are used. Emphasis is given on naturopathic modalities like natural substances, use of foods, fruit, juices, vitamins, minerals, enzymes, digestive aids, herbal substances, and other natural substances. Treatment is also given with the help of earth, water, sunlight, and air, because these are the 5 elements which are available in our body also, which are available in the universe. So we try to adjust or try to have the toning of those things with the help of these elements. Naturopathy, more than complementary therapy, is a system which believes that healing depends on the vital curative force within the human being. That's what we try to give the body detox, which enhances the immunity of that person and which helps in getting rid of the particular problem. And Hippocrates, the father of the modern medicine, formulated the basic naturopathy concept. Naturopathy is the first and foremost a preventive system of medicine aimed at maintaining and promoting all health, though also for curative purpose, because in the naturopathy treatment, we have eliminative diet, curative diet, and preventive diet. These are the 3 types of diet we use and which helps to maintain the good health, particularly after the treatment in naturopathy. Next. So conclusion, by investing in the food safety innovations and fostering the strong proactive culture of the hygiene, you can create a safer and more welcoming environment for your guests while also enhancing your business reputation. Remember, food hygiene and safety are an ongoing commitments that require continuous attention and improvement. So I believe that food can work as a medicine in most of the cases. Next. So thank you very much for giving me this opportunity. And if you have any questions, I welcome.
Thank you so much, Dr. Prakash. It was an excellent presentation.
Yeah, thank you very much.
Yeah, once again, thank
Any
you so much.
questions?
Interruption. It's about loving yourself as you are. The way we age is about the structures that are affected in the processing of time. So aging, it's a process that affects mainly the skin. It's what we're going to see in this presentation. The skin has, the skin has collagen loss, it's decreased, and we lost collagen, and the structure is really like down. We have fibroblast decreased activity and cellular senescence. Are you like familiar with this cellular senescence term? It's the skin is the largest organ in the body. So one of the first things that I wanted to show to you is that collagen depletion, volume loss, textural changes, it all affects the way that you can see the aging processes. There are just cosmetic but situations that affect the skin, but in these things, it's not important just the cosmetic part or the aesthetic part. It's that the skin looks saggier, and that is what the patients don't like. So skin begins to have this collagen loss in a cellular levels. Fibroblasts stop dividing efficiently, and type collagen degrades. The elastin fibers become deorganized. So over time, that leads to a thinner skin. That's a really important thing, because from now on, we're going to see how the skin, the thinner skin affects the aging processes, and collagen stimulator like polycopolactone can thicken the skin. So we are going to see that in a biopsy situation. There's reduced elasticity, and that gives you this dull, tired look that the patients don't like and associates with aging. What's interesting in this process doesn't just happen with time, it's also accelerated by environmental stressors and inflammation. So people that smoke, people that don't sleep well, people that have this bad lifestyle, it also affects to the aging processes. So the thing here is how the real challenge is how do we reawaken these fibroblasts? So let's talk about the cascade in the fat redistribution process. This is the fat pads in a AI created image. So this is how the fat pads redistribute in the face. The muscles are weaker and saggier. So we have to understand that collagen is just structure. When we lose collagen, we'll lose the structure. And this is what aging happens. We all know that we deplete collagen 1% per year since we are 25. So that it's really young. If you think about someone with 25 years old, it's young, but it's already starting to lose and deplete the collagen production. There's also bone reabsorption, and this is really important because there's nothing we can do about bone reabsorption. We can restitute bones, obviously, but we can do collagen stimulators to give this structure that has been lost. Okay, so here I have a video. Can you see it properly? Okay, in this video we see how this is from a brand that works with polycopolactone. I do not work with any brand. I do not have any conflict of interest, but I think this video is really illustrative about how this works. Okay, so there's tissue regeneration and improved skin quality when we talk about collagen stimulation. So collagen is more than a buzzword, it's just the architecture of the skin. Type 1 collagen gives us the structure, thickness, and resilience of the skin. And since we are in the mid-30s, we start to produce less collagen every year. So each decade, each year, it declines continuously. The skin becomes thinner, the skin becomes weaker, and the wrinkles starts to appear, not just for movement that we also trigger with botulinum toxin, but with weakened foundation, okay? So if we can stimulate the right type of collagen, like it's type 1 collagen, we can rebuild this structure that it's been lost. So here is the interesting part and what I wanted to expose about the article that I wrote almost a year ago. It's about this. This is like the main thing you have to remember when it comes to collagen redistribution. The dermal thickness was increased in 26.7%. This is the improvements of the dermis. Obviously, there was a fibroblast activation and type 1 collagen production, also with vascular growth, which give us this, it depletes this kind of dull and aging situation. There's also like a crosstalk with keratinocytes and adipocytes. But the thing about this is that the improvements of the dermis were like in a long-term situation. It was for over 4 years. So this is a really good treatment. In an histological procedure, there was biopsies performed in a lot of studies. This was a systematic review. And the histological feature was that the PCL is polycaprolactone, PCL was redistributed evenly, and it lasted for up to 4 years, the stimulation of the collagen production in the fibroblast, and there was dense collagen type 1. So this is really important because we can actually rebuild the skin from inside out. So this was not part of the article, but I do want to talk about application process. This is an AI image of myself when we can see how can you apply the collagen stimulator to redistribute the structures. Obviously, this is not in an old woman that it's more noticeable, but this is the points that I would like to inject the collagen stimulator to give this lifting situation and to improve the collagen. What is good about the PCL is that you have an immediate effect, that it's a volume situation, that it's not going to last long. It's just because of inflammation of the liquid that you're injecting in. But in the meantime, you're going to start producing the collagen that it is meant to produce. You're going to start stimulating the fibroblasts that you're meant to stimulate. This is really important because you're going to give an immediate effect what the patients are going to be really happy about, but you're going to be also giving a long-term situation. Next slide is a patient of mine that we did the application process. He had a problem of over voluminization that I wanted to talk about because that was with fillers of hyaluronic acid. You can see in the temporal fossa that it's really overfilled. And it had like this aspect of an ill man that he didn't like. That's how he described it himself. And we worked with combined therapies. We worked with polycaprolactone fillers, and we worked with lasers that I'm going to talk about in a moment. And we really improved the texture of the skin from inside out. So this is a really, really good outcome, and it's a long-term outcome. So you may ask yourself why choosing the polycaprolactone filler instead of hyaluronic acid. It's a really good question because hyaluronic acid is one of the most used products in the market, and it's also famous. So patients talk about this. Patients want to get fillers because it's what they see in celebrities like Kim Kardashian, like Lindsay Lohan, and all the celebrities that are viral from their looks. So we have to instruct the patients that hyaluronic acid is not always the best outcome. So let's compare hyaluronic acid. It's still the most common filler, but when it comes to rejuvenation, it's just volume and it has limits. With PCL, you can offer both. You can offer, like I was talking about, an immediate correction, and you can talk about biological stimulation that lasts longer and builds collagen from inside out, and also improves the skin quality. Skin quality is a term that you have to remember because it's the future of the well-aging and anti-aging medicine. And you may ask yourself, this is not about dermatology at all. It is. It's about dermatology because it's skin quality. We work in the skin to look healthier and we work in the skin to look better. So when it comes to dermatology, there's nothing more dermatological proven that something that increased the thickness of the dermis in 26.7%. The patient's looking from something deeper. The PCL, it's not a substitute of hyaluronic acid. You can mix in a different areas, but you can really, really take a step forward when we talk about this. So it lasts longer, it improves type 1 collagen, which hyaluronic acid does not. And it has an immediate effect and a long-term effect, where hyaluronic acid just have an immediate effect. Here is what is the most important thing, like it or not. The patients will look for the satisfaction in the consultation. If you don't give them the expectations that they have, they're not going to be happy with the treatment that you offer. So when it comes to patient satisfaction, there's this scale that talks about, this is a global aesthetic improvement scale that's called GAZE. It's about the improvement. It's just a bunch of questions they do to the patients. So how do they feel themselves with these different treatments? So the improvement with collagen stimulators was up to 90%. That's a lot. And the best part about this is that you can give a 90% improvement according to the patients, but you have mild adverse effects. This is really important. There's mild adverse effects reported. There was a lot of studies reviews in this article that I wrote some time ago. Over 780 patients and more than 1,000 treatments were performed. So there was none adverse effect that you have to worry about, like granulomas or like infection or anything you have to worry. Obviously, there was edema, there was bruising, malar edema. It's common when you inject that area, and there was palpable lumps because, like we said before, we give a correction in 2 times. We give the immediate correction and we give the long-term correction. So when the immediate correction happens, there is possible that the patient tells there's palpable lumps. And the interesting part about decoloration is that it was related to immune diseases. So vitiligo and all these kind of diseases, you have to be careful not to obviously inject an active area of any immune disease. And something I'm really, really, really passionate about is combining therapies. I do think that polycaprolactone filler is a really good product, but sometimes it's not workable just as itself. We have new vessels, we have new collagen, we have new structure, but the thickness of the dermis is not just about how it looks on the inside and in a biopsy, it's how it looks on the outside. In the patient that I showed you before, there was a patient that has acne scars. So it's not just enough to get the polycaprolactone filler. We have to also work with lasers. That's what I remain to say, that combination therapies are really important. For the best results, there is an understanding that we have to combine the therapies that we can. So in this patient, what we did was we injected polycaprolactone filler, and we also did laser treatment with picosecond and CO2 to improve the quality of the skin. The best results come from the understanding that this works in layers. That's why I started this presentation talking about the layers and how it is affected by the aging process. So let's use the right tools to improve each layer of the skin. Threads can leave, hyaluronic acid can fill, but PCL can rebuild the skin from the inside out. And with the laser, what we do is we rebuild the skin from the outside in. So this is like, I tell to the patients, this is like a sandwich. We work in the different layers of the skin to get the most improvement that we can. PCL is the foundation of the new aesthetic medicine that just not triggers anti-aging and to look overfilled and to look not natural. It gives you yourself but better. And it also improves the healthiness of the skin. That's really, really important. So I think hyaluronic acid as the biological primer, like the base layer of a generative plan. There's a lot of things that you can do in generative medicine, but I think PCL is the best outcome. And you're gonna ask, how about the combination of different collagen stimulators? There's also like polylactic acid, polyglycolic acid. I do think that when it comes to structure, PCL has the best outcomes in the articles that were reviewed. So I want this slide to be the most important to you. This is the clinical pairs that you have to keep in mind when you work with PCL stimulator. First, there's like a debate in the scientific area if we want to do the dilution with lidocaine, because we all know that like this comfortable and kind of like soothing situation is really important to patients. So you can mix PCL with lidocaine in a 1-to-1 proportion. And you can also do a tumescent like liquid situation on the area that you're going to work, but it's not needed. Tumescent anesthesia, it's really like heavy for heavy procedures, and like PCL does not need just, it would be better if you do just 1-to-1 lidocaine dilution. That's the ideal one, according to the studies that were reviewed in this article. We use in deep layers of the skin, we can use the PCL in a deep layer, and we can also use it in a subdermal plane. In this case, with the patient, I'm going to return with the patient. We did both. We did like I showed right here. The punctures are the ones that we did like over the bone, and the ones that are arrows, it's the ones we did in a subdermal plane to improve the texture of the skin. So you can work with both application processes and it gives you the best outcome. This works really well to avoid overproduction. We can see in this patient that there's an overcorrection of temporal fossa, and there's also this aspect of thinner face. But the patient did not like this like cadaveric face. Like he said, he looked like he was ill all the time. So we did like a more natural outcome. He is actually 43 years old, and you can't actually say. and he has a really improved quality of the skin from the before and after picture. Okay, the combination with other modalities, it's really important. Combination with hyaluronic acid for more structure, combination with frets for more lifting. It's a really good situation, but the best thing you can do is combination with energy-based devices. I am really passionate about energy-based devices because I think they give really good improvements, and I think they're the future of the dermatology. So when you combine these injectable therapies with the therapies that you can do with laser, or maybe even peelings if you don't have lasers in your consultation, it can be really, really beneficial for the skin. And the results improve over time. This is very important because patients are not patient. They want just the results to be from one day to another. And with any collagen stimulator, but especially with PCL, you cannot promise the patient that it's going to be just as they finish the consultation, they're going to look at its best. You have to instruct them that it's going to be a really slow process that works over time. I tell the patients that you have to wait 2 months from the first application to see the actual improvement of the quality of the skin, because collagen productions take time. It's really important that you don't mix with any heat energy-based device right after. You can do it the other way around. You can do the laser first and then the PCL, but you cannot do it first the PCL and then the energy-based device, because collagen, it's a really weak protein that when you start to stimulate it, it's really weak. So if you give heat or any stimulation, you can break the collagen, and it's not going to be as the outcome is not going to be as the best as it could be. Okay. To my liking, this is the future of rejuvenation process. It's a long-term regeneration. It gives the skin longevity strategies, and you can do a personal biostimulation because you can mix with different situations and different technologies, so you can give each patient the best outcome. So to me, it's not about reversing time, it's about restoring confidence. I do not like these patients that want over-volumized faces and not natural aging processes, but I do like to help my patients to look at its best. So this is what I wanted to transmit it to you, because I do think PCL is the future of anti-aging and well-aging medicine. So I don't know if you have any questions or you want to talk about the application process or how to mix with different energy-based devices. Thank you so much for your time. And I think this, if you explore the polycaprolactone filler in your clinical practice, it's going to be really fulfilling results. You can also see my social media and my email if you have any further questions or you want to read the article yourself.
Yeah, thank you, Lorena. It was a wonderful presentation, and the topic you have suggested is very, very good. And only thing is that I just wanted to know how about the cost part? That is, how much cost the person will.
We see you.
Okay, thank you. Well, so we're going to talk about a 19-year-old female. She is originally from and current resident in Mérida, Yucatan, with no family or personal medical history reported. Her only notable background is a positive history of methamphetamine use. So the evolution of the dermatosis should start a month prior with the presence of a progressive erythematous vesiculous dermatosis in photoexposed areas. 2 weeks later, the lesions progressed to erythematous squamous plaques on the face, scalp with necrotic crust in the oral and perioral regions. And later in March 2023, she came to our unit due to worsening of the conditions with presenting fever, asthenia, headache, and in addition to the previous associated dermatosis. So about the dermatosis topography, it's a disseminated dermatosis affecting the head and neck, predominantly in periocular region, nasal dorsum, cheeks, and perioral area, auricles, and anterolateral neck, as well as the upper extremities, bilateral and symmetrically on the anterolateral arms. About dermatosis morphology, we have is characterized by squamous erythematous squamous pink plaques with fine sculling and infiltration appearance at the edge, irregular and well-defined. And in the upper extremities, we have in the arms, these plaques show with the presence of hemorrhagic crust, as well as erythematous brown macules. And in the vermilion border of the lips, the hemorrhagic crust and erythematous brown macules were also observed in this area. So, based on the clinical presentation and the patient history, the initial presumptive diagnosis were an Stevens-Johnson syndrome or a toxic epidermal necrolysis versus an acute syndrome of apoptotic panepidermolysis. So, what do we know about 10? The causes or triggers is the hypersensitive reaction to the drugs. Here, based on the patients, some illicit methamphetamines formulations might contain sulfonamides, which could act as a pharmacological trigger, but it's not also clear here in this case. And in this intent, we have most of the times the drug very clear. So in this case, it's not clear. And clinical features, we have then acute onset with purpura macules, blisters, epidermal detachment, and mucosa involvement, which we not have with our patient. We don't have the mucosa involvement, and it was a very insidious onset. And what do we know about the acute syndrome of apoptotic panepidermolysis? The causes or triggers are the active systemic lupus, UV light infection, and occasional drugs. So I also find some case reports in the literature that associated the levimazole, which is known as a component of the methamphetamines. So it could be a possible trigger too, but it's not clear also in this case. And what about the clinical features? We have 10-like lesions in part of distribution without mucosa involvement, and with not a clear drug trigger. So we do some laboratory tests in our patient at the first. So they show normocytic hypochromic anemia and hypertriglyceridemia with the rest of the complement blood count, the liver function test, the blood chemistry, the viral partner were within normal parameters. We also do aleatory urinalysis with significant proteinuria documented and confirmed by a 24 hours urine collection. We also observed an elevated acute phase reactant such as CRP elevated. We have additional complementemia, a very noted complementemia, and positive antinuclear antibodies, anti-DS-DNA, anti-SMID, and anti-beta-2 glycoprotein antibodies in the laboratories. So also a skin biopsy was performed with hematoxylin and leucine, where the following observed of the atrophic epidermis, hyperkeratosis and asponghiosis, vacuolar degeneration of the capal layer, and with necrotic keratinocytes. In the papillar dermis, we can observe the perivascular erythrocyte extravasation, and in the reticular dermis, we can observe this interstitial deposit of mucin. So we also perform, do the documentation of the proteinuria, a renal biopsy with immunofluorescence, where we can see a revealing focal proliferative glomerulonephritis due to immune complex and active tubular interstitial nephritis and focal acute tubular injury with a mild regenerative epithelia change. And the direct immunofluorescence show a positivity for IgG and C3. So how do we do the differential diagnosis with TEM versus the acute syndrome of apoptotic panhyperemolysis? We have this table with the differences, the clue ones. So the trigger, a drug hypersensitivity in 10. It's very noticed, it's very clear in the most of the cases, which we don't have this in this patient. The acute panhyperemolytic syndrome have an SLA predisposition and UV light exacerbation. The distribution in 10, we have a diffuse dermatosis, and in acute panhyperemolytic syndrome, we have more like the photo distribution in this case. A very affectance mucous membranes we have in 10, and it could be a mucous membrane involution in the apoptotic panhyperemolytic syndrome, but it's not it's not very common. Multi-organ involvement, we have a systemic toxicity in both, but in 10 we have more involvement of the pulmonary and liver, and in the panhyperemolytic syndrome we have more kidney involvement, like in our patient with a nephritis. Hypercoagulable state, we have non-affection in 10, but in panhyperemolytic syndrome, with our patient, we have a positive anti-beta-2 glycoprotein, which is associated with an hypercoagulable state. And in laboratories, we have an eosinophilia in most of the cases in 10, and well, the positive antibodies like anti-nuclear antibodies, anti-dsS-DNA, and anti-SMID in our patient, because we're talking about lupus. So our definitive diagnosis, we have an acute syndrome of apoptotic panhyperemolysis, a class 2 lupus nephritis, and a SLA with a high disease activity with an SLA with 34 points. So in the evolution of our patient, we start methylprednisolone pulses, where we started along with a topical treatment with hydrocortisone and petrolatum, with the remission of the dermatosis 2 weeks after the start of the treatment. So we have here the evolution of the dermatosis. 2 weeks after the start of the treatment, with the presence of erythematous brown and light brown macles, circular in shape with well-defined and regular borders. Some are extending to coalescent, evident decrease of the erythema, and no presence of the hemorrhagic crust. So no presence of the hemorrhagic crust and no affection from the mucosa area. So systemic lupus erythematosus can present with multiple cutaneous manifestations, including an acute syndrome of apoptotic panhyperemolysis, which is very rare, less than 0.07%, but it's clinically severe and similar to Stevens-Johnson's syndrome and toxic epidermal necrolysis. And it is also associated with a high lupus activity, making an early diagnosis crucial. We can change the prognosis of our patients by detecting this disease very early, having a very high suspicions of this disease. So we already talked about this, but for the diagnosis, what do we do with the point marks to make the difference from an Stephen Johnson or 10? But the acute syndrome of apoptotic panhyperemolysis, we have an insidious onset, as our patients do, the photo-distributed dermatosis with no mucosal involvement, the anti-nuclear antibodies positive, the proteinuria, and the renal involvement. And in 10, we have an acute onset less than 9 days, affects mucosal membranes, and directly related causality, like very clear. So in the histopathology, the difference that we can find is the type of the necrosis. In 10, we have a massive necrosis, and in the panhyperemolytic syndrome, we have an apoptosis isolated with keratinocytes. The location in 10, we have a generalized epidermical necrosis, subepidermical blisters, and in the panhyperemolytic syndrome, we have the focal necrosis and mainly the basal and superficial dermal areas. About the inflammation, we might not have inflammation or mild inflammation in 10. And in the panhyperemolytic syndrome, we have dense dermal inflammation with lymphocytes. We can also found leukocytoclastic vasculitis. And the basal localization, we have a prominent basal localization as we see in the panhyperemolytic syndrome. And the main clue for the diagnosis is the monofluorescence. It could be negative or non-specific in 10, and we will have the deposit of IgG, IgM, and C3 in the dermoepidermical junction. In this case, we didn't do the immunofluorescence in the skin biopsy, but we found these deposits in the renal biopsy. So the early detections achieved by maintaining a high index of diagnosis suspicious along timely management reduce the risk of complication, especially in this case, renal complications and mortality in these patients. So the take-homes we consider are the panhyperemolytic syndrome in necrotic dermatosis with a photodistribution pattern, especially in the absence of trigger drugs. The histopathology is essential to differentiate it from Stephen Johnson syndrome and 10, and in early diagnosis allow for timely immunosuppressive treatment, prevent severe complications, which are associated with a high lupus activity. So that's all from me. Thank you for joining this presentation and for your time. If you have any questions, I'm open to questions.
Thank you so much, Dr. Monica. It was an insightful presentation. Once again, thank you so much, Dr. Monica.
Good morning. Thank you to the organizing committee for the invitation to this third International Conference on Dermatology and Cosmetology. I will talk to you about laser devices in dermatological surgery, and I will show you a little of my experience in representative clinical cases of therapeutic challenges that I have treated in my clinic. About the disclosure, I don't have conflict of interest, and these are the devices that I use in my daily clinical practice. Today, there is growing interest in minimally invasive surgery. In many areas of surgery, and particularly dermatologic surgery, techniques have been refined, and in many cases, incisions are no longer required, or smaller ones are required. There are many types of lasers that differ in the wavelengths of light emitted, their power, and their ability to coagulate, cut, or vaporize tissue. Laser therapy is sometimes used alone, but it is often combined with surgery, chemotherapy, or radiation therapy. The advantages of these instruments are greater selectivity for tissue damage, non-contact cutting precision, the cutting site remains sterile, allows for faster patient recovery. We have a cleaner surgical field due to less bleeding, reduces overall surgical time. Although it could be said in general that the results are more predictable, they are also operator dependent, and the surgeon's experience plays an important role. For the above reason, in many cases these are procedures we cannot delegate to our paramedical staff. In my opinion, any ablative laser should be for the exclusive use of the physician, and what we could delegate are procedures with some non-ablative lasers or devices with the appropriate training and supervision of the attending physician. The specific properties of lasers in target structures and tissue layers have made them an important method for reconstructive surgery and anti-aging treatment by inducing new collagen formation systems using CO2 and air YG lasers to target specific portions of the dermis. The selective photothermolysis is the physical-biological principle by which a laser can destroy a specific target, chromophore, in the skin, such as melanin, hemoglobin, or water, without damaging the surrounding tissue. It was proposed by Anderson and Parrish in 1983. In dermatologic surgery, we typically use ablative lasers. In the postoperative period, we assist with non-ablative or fractional ablative lasers. These tables show that the most ablative laser par excellence is the CO2 laser, followed by yttrium-switched erbium, argon, and garnet. Melanin chromophore lasers include ND, YG, alexandrite, and diode lasers. The ability of lasers to selectively target pathological vessels makes them a primary source for the treatment of vascular defects such as port wine stains. Lasers that are preferentially absorbed by hemoglobin rather than melanin are the pulsed dye laser, the KTP laser, and the long-pulsed ND, YG laser. Laser tissue interaction. How does one know that a therapeutic dose of energy is being delivered? Lasers usually elicit immediate or short-term responses of the skin. These laser tissue reactions are endpoints, and they can provide a reliable indicator of treatment response. The clinical endpoint depends on both the laser or light treatment used and the target of the laser. Selective photothermolysis treatments for hair removal, tattoo removal, and vascular and pigmented lesions have distinct endpoints. Some endpoints act as warning signs of injury to the skin. Others can indicate a therapeutic response. The article of Molly Warner and collaborator is very interesting and describes not only therapeutics endpoints, but also undesirable and warning endpoints of diverse lasers. The specific endpoints vary with the type of laser, with proper use of the laser, and with the histologic target involved. Observation of clinical endpoints is crucial for the adjustment of laser parameters during treatment, both to increase efficacy and to avoid side effects. Immediate and early skin responses or endpoints are seen during various laser treatments that correlate with therapeutic outcomes. Key points D endpoints depend on multiple factors, including laser wavelength, pulse width, target, fluence, and skin type. If an endpoint is not achieved, increasing the fluence may not be the solution. Always look carefully for warning endpoints. Achieving a therapeutic endpoint does not guarantee the absence of side effects. Careful observation of therapeutic endpoints is more reliable than using recommended or preset laser settings as the primary guide during treatment. The effects of lasers on tissues depend on multiple variables: wavelength, pulse duration, fluence, and target chromophore. These effects can be classified into 4 major mechanisms of action. Photostimulation or photobiomodulation. Its effect is biochemical, non-destructive, promotes cell regeneration, stimulates mitochondria to release reactive oxygen species, and reduces inflammation. Examples include light-emitting diode lasers, or LED, and low-level laser therapy, or LLT. Photodynamic. Its effect is biochemical and cytotoxic, requires a photosensitizing agent, uses light of a specific wavelength, and is used to treat inflammatory acne, actinic keratosis, basal cell carcinomas, among others. Photomechanical or photoacoustic. A shock wave is produced by rapid thermal expansion, causing fragmentation of the chromophore, in this case melanin, without profound thermal damage. The pulses are ultra-short and high intensity, such as those of the ND, YG or Q-switched ND, YG laser, ruby lasers, and alexandrite lasers. They are used to remove tattoos and various pigmented skin lesions. Photothermolytic produces a localized and controlled temperature increase that can be ablative or non-ablative. We also observe the effect of protein photocoagulation and photoablation, which refers to tissue vaporization. The lasers used are CO2, air, YG, ND, YG, and vascular lasers such as PDL or aniline lasers. Depending on the temperature reached, the effects on the tissue can vary, as seen in the table. A. 37 to 60 degrees Celsius, tissue retraction. B. 60 to 90 degrees, protein denaturation and coagulation. C. 90 to 100 degrees, carbonization and amp, burning. D. Moss to 100 degrees, tissue is vaporized and ablated. The laser's output parameters determine its behavior and biological effects. These must be adjusted according to the tissue type, the therapeutic objective, and the safety of the procedure. I won't go into detail here since we all know what these parameters are, but I'll just remind you in this table: fluence, power, frequency, and pulse duration. The pulse type can be continuous wave, but it only vaporizes the skin superficially and generates greater heat, damage, and recovery time. This is where lasers above 2000 nanometers come in. Subablative pulses, generally with wavelengths shorter than 2000 nanometers, are generally more superficial and fractional, causing less tissue damage and faster recovery. High pulses, such as superpulsed and fractionated, tend to be deeper but more selective, with less damage and better recovery. This is the most appropriate type of laser for stimulating collagen formation in acne scars and deep rhytides. Below, we will discuss the clinical uses of lasers in skin neoplasia and illustrate with clinical cases. There are several applications for skin neoplasia. Here we will take advantage of two effects: photodynamic and photothermal. Direct laser ablation, through its photochemical and photothermal effects, has been used to directly destroy cancer cells. Photochemical reactions produce toxic radicals that cause tissue death, generate tissue stress and fragmentation, and induce heating, blood coagulation, and cell death. This treatment involves the administration of a photosensitizing drug, followed by illuminating the target area with visible light proportional to the drug's absorption wavelength. The photosensitizing drug forms an excited state that generates reactive oxygen species that are destructive to neoplastic cells through apoptosis. Selective photothermal therapy uses the best light-absorbing dyes to enhance laser-induced tumor cell destruction through ischemia and tumor necrosis, followed by tissue remodeling and formation of new collagen fibers. Here, I present the case of a 49-year-old female homemaker originally from and residing in Tamazula, Jalisco, Mexico. She consulted us for congenital neoplasia on her feet, hyperhidrosis, bromidrosis, and recurrent infections. She has received multiple treatments throughout her life, including drying agents, isotretinoin, vitamin D, and analogs such as calcipotriol and oral zinc. It was decided to take biopsies from 3 different representative areas, and the diagnosis was eccrine syringofibroadenoma. Diagnostic imaging studies ruled out involvement of deeper structures with only skin involvement. With the diagnosis in hand, we plan to perform 2 different but complementary procedures. On the left foot, we will perform a combined treatment by excising the most voluminous area and then applying a full-thickness graft taken from the abdomen. The rest of the foot was treated with a continuous wave CO2 laser. On the right foot, only the continuous wave CO2 laser was used. This is the video showing the procedures performed during surgery and the postoperative laser procedures in several sessions. Here are some more recent photographs that the patient kindly sent me to my cell phone showing the current condition of her feet. Truly spectacular. This case is interesting because the CO2 laser treatment achieved the same results as the grafting areas, with a shorter recovery time and less pain reported by the patient. However, it is important to emphasize that not all cases will progress this way, and individualized assessments should be made based on biopsy and imaging studies. This is another interesting case of skin appendage tumors. The patient is a 54-year-old man who works in a transit office in Guadalajara, Jalisco, Mexico. He has hypertension. 5 members of his family have the same condition, including his daughter. The reason for his consultation was burning pain, erythema, occasional flare-ups, moderate nasal obstruction, and a general desire to improve his appearance and boost his self-esteem. A polarized contact dermatoscopy reveals a white ivory background, bright white lines, and yellow to light brown dots and clods. Histopathology with hematoxylin and eosin stain reveals multiple horn cysts and aggregations of basiloid keratinocytes surrounded by a fibrous stroma. So the diagnosis was multiple trichoepitheliomatosis, in this case a familial multiple trichoepitheliomatosis. Below is a video of the patient's first procedure. Two more sessions were subsequently performed, combining CO2 laser therapy in continuous wave mode. Another condition in which combining surgery with ablative lasers is very useful is phimosis rosacea, particularly rhinophyma. Today, we know that rosacea patients can present with a combination of symptoms that do not necessarily fit into a rosacea subtype. This is where we talk about rosacea phenotypes. According to the latest consensus statement from the National Rosacea Society, the mere presence of rhinophyma is definitive for the diagnosis of this condition. This is the topographic classification of phimosis rosacea, but we will focus on rhinophyma. Many procedures have been described for the treatment of rhinophyma. However, 3 characteristics define the method of choice. 1. Degree of severity, which is determined by the inflammatory activity and the size of the rhinophyma, which can deform the nasal anatomy. 2. Availability of the technology. 3. Experience of the dermatologist. In many cases, controlled rosacea is required, and it is advisable to premedicate patients with topical isotretinoin and/or retinoids or other pharmacological treatments, depending on the clinical context. The CO2 laser offers a significant advantage by maintaining a precise cut and a cleaner surgical field with less bleeding and faster recovery. The procedure includes delineating the aesthetic subunits of the nose, the nasal dorsum, lateral walls, nasal tip, soft triangles, and nasal tip, since these boundaries have been lost in severe cases. The patient undergoes surgery on an outpatient basis in a conventional procedure area using anesthetic blockade of the external nasal, infraorbital, and nasopalatine nerves. In the first stage, we perform decortication with ablative radiofrequency and subsequently use the continuous wave CO2 laser to shape the subunits, contouring and always verifying symmetry. The nose has an impressive capacity for regeneration by secondary intention after these procedures, but special caution must be exercised on the nasal tip and ale, as the underlying cartilage is very close to the skin and can be damaged. Our endpoint in this case is the visualization of the sebaceous glands, and it is preferred to perform THS split technique, first one side and then the other side and layer by layer, just like an onion. This is a scheme we propose for the therapeutic approach to rhinophyma according to the degree of severity. As I told you before, always respect sebaceous glands, nasal subunits limits, and symmetry with the help of split and layered technique. At the begging star with most ablative devices to perform a carefully debulking and session by session decrease and adjust of device or laser parameters until refinement this low fluences and improve texture, color, and pores. Below are some clinical cases. This is the case of a 47-year-old lawyer residing in Guadalajara, Jalisco, Mexico. He had no relevant medical history. His complaint was burning sensation, erythema, occasional rashes, and moderate obstruction due to nasal deformity. He was premedicated with 20 milligrams of isotretinoin daily for 2 months and then proceeded to perform a first session with Elman ablative radiofrequency and continuous wave CO2 laser using the parameters shown on the screen. From the first session, an impressive change was observed. However, refinement is still needed. Subsequently, 3 months later, we performed fractional CO2 laser and pulsed dye laser for the residual erythema. It is worth mentioning that the patient was discontinued on isotretinoin during recovery and then restarted at moderate to low doses with gradual tapering. This is another case of a patient with severe rhinophyma. The patient is a 34-year-old male mechanic originally from and resident in Tlaquepaque, Jalisco, Mexico. He has no significant medical history. He came to the clinic for a significant nasal deformity, along with acne breakouts, abscesses, and mild pain. After premedicating with isotretinoin for 3 months, it was decided to proceed with 2 sessions of Elman ablative radiofrequency combined with continuous wave CO2 laser and 2 sessions of hyperammeter fractional CO2 laser. This is the result 2 months after his last session. She is currently continuing low-dose isotretinoin and pulsed dye laser therapy, and another session of fractional CO2 laser therapy are planned with parameters to refine the pores and further improve the texture and profile of the nose. Removal of filler material. Lasers are an excellent device to combine with surgery for the resection of paraphenomas and permanent filler material. Injective treatment with soft tissue filler is the second most frequently performed aesthetic procedure after botulinum toxin type A in Mexico and Latin America. Although resorbable materials like hyaluronic acid are most frequently used, a number of permanent materials are injected to enhance soft tissue volumes and fill subcutaneous defects. Mostly of this permanent filler are nowadays prohibited in many countries, but we are currently watching the delayed effects of this filling materials. It is well known that non-resorbable substances remain for decades in the tissues and can potentially cause inflammation at any time and are associated with autoimmune reactions such as Asia syndrome. This is the case of a 39-year female, businesswoman, Guadalajara, Jalisco, Mexico. She has also hypothyroidism. She consulted me about edema, intermittent pruritus, swelling, morsicatio buccarum, and lingarum. Other clinical manifestations were urticaria, myalgia, fatigue, insomnia. Her symptoms have been developing for 6 months and worst for the last month. As an important background, the patient reports having had a filler of unknown type applied by an aesthetic doctor 10 years ago. We then decided to perform 2 biopsies from representative areas, both of which confirmed a paraphenoma with a lymphocytic inflammatory reaction around the filling material, as seen in this H and AMP, microscopy image. She was referred to and treated jointly with a rheumatologist, who confirmed that she had Asia syndrome. Treatment was started with levetiracetam, montelukast, and methotrexate 10 milligrams weekly, along with folic acid and colchicine 1 milligram daily for 6 months, with subsequent tapering doses. Glutathione was also prescribed as an antioxidant, along with supplemental vitamin D. This table shows the Schoenfeld and Agman-Levin criteria for Asia syndrome, of which our patient met the criteria listed. Confirmation of the diagnosis requires only 2 major criteria, or 1 major criterion and 2 minor criteria. Below we see the procedures performed on the patient. First, a material removal with open surgery plus continuous wave CO2 laser was performed. The filler material was visually compatible with polymetal metoacrylate. Here we can see the postoperative picture at 14 days. Then this is the evolution after 2 months and localized resections with punch plus diode laser plus superpulsed fractionated CO2. 3 sessions were held in total. Here is the patient after 2 months with a better mouth function and smile, and we performed localized punch plasties plus diode laser plus superpulsed fractionated CO2. Here is after 3 months, and we began to perform infiltrations with enzymes, collagenase plus lipase plus hyaluronidase plus triamcinolone. 3 sessions were held in total. Finally, result is after 3 months of last session. Here we see the patient 3 months after the last enzymatic infiltration session, completely asymptomatic with adequate mouth opening and remission of inflammatory activity controlled by rheumatology. This is a study published in 2016 by Italian plastic surgeons that evaluates the efficacy of minimally invasive intralesional laser treatment, 808 nanometers, to remove permanent filler material and control inflammation. The study included 219 patients and included fillers that caused cystic and/or infiltrative lesions of various topographies. They conclude that therapy with an intralesional 808 nanometers diode laser fiber is effective and minimally invasive, with a 92% success rate, although it should be noted that in some patients, improvement was partial. Ultrasound is a very useful tool for differential sonographic diagnosis between infiltrative and cystic patterns and for guiding us to the type of filler material, as well as its depth and distribution, and therefore guides us in the therapeutic approach to be taken. This graph shows the most common complications from permanent fillers, the main one being chronic edema. We also perform surgical techniques combined with lasers for vitiligo. An interesting therapeutic option for patients with treatment-resistant vitiligo is melanocyte transplantation combined with erbium YAG and excimer lasers. It should be performed in patients with stable vitiligo, meaning no new lesions or progression for at least 6 to 12 years and resistant to medical treatments. The goal is to recolonize achromatic areas with functional melanocytes obtained from the patient. In the image, we are showing cases of patients treated with these techniques, provided by a colleague who is an expert in the field. Another very common reason for consultation is acne scars. Regarding acne scars, the scope is very broad, and there are various treatments, many of them complementary. This is the 2022 International Consensus on Energy-Based Devices for the Treatment of Acne Scars. The therapeutic approach will depend on the type of scar. For example, if the scar is erythematous, box scar, intense pulsed light, IPL, can be used to reduce erythema, or pulsed dye laser, PDEL, can be used for the same purpose, followed by fractional erbium laser or fractional radiofrequency with microneedles. For deep atrophic scars, subcisions and plasty are suggested. For ice pick scars, we perform excisionplasty using the punch technique. For hypertrophic scars, we use pulsed dye laser, intralesional application of triamcinolone or 5-fluorouracil, laser-assisted drug administration, and fractional CO2 laser. For scars with post-inflammatory hyperpigmentation, especially in darker skin types, we recommend using diag picosecond laser or diag switch laser. Here we see the excision punch technique and the before and after. This is the case of a patient who presented with post-inflammatory hyperpigmentation after having seen a cosmetic physician who performed microneedling for scarring-type acne scars without proper preparation. Finally, we have fractional CO2 laser-assisted hair transplantation. This fractional CO2 laser from the company DECA offers programming and adjustment assistance in the formation of microincisions for follicular unit implantation. It has been shown to reduce the time of this procedure, as well as reduce bleeding and inflammation at the follicular implantation site. Conclusion: the finding from the present review indicates that laser surgery is spread vastly in medicine. This approach is associated with less bleeding, short time of recovery after surgery, and less side effects. High cost and its dependence on a specialist surgeon, applying a suitable setup of laser, and also finding standard laser devices are among the considerable difficulties with laser application in surgery. It's always important to maintain control of the condition being treated both before and after these procedures and to have a network of specialist colleagues for multidisciplinary treatment when needed. Thank you very much for your attention.